And so we draw the cracks in that wall.
So I mean, we're trying.
No, not yet.
Well, look at execution process.
Okay. I think
So get your pencils and papers out. A lot of the start of this meeting is soon. Thank you and have a good day.
We can start with Margaret, if you don't mind.
Sure. I'm Margaret Liu. I'm the policy analyst for the program doing rules and communications.
I'm Melanie Farnsworth. I am new, and I am a retired nurse practitioner, many years of experience in palliative care and oncology.
Andre Uso, the manager of the medical marijuana program.
Sarah Bennett, accidental activist turned intentional advocate, dispensary owner, farmer, and distributor.
Hi, Bob Blake, kind of the same as Sarah, more on the medical research side, but also a cannabis grower, processor, dispenser, and wholesaler.
Hi, Art Richards. I'm representing the MS Society of Oregon, an advocate.
Allegra Rainey, patient advocate, co-owner of Collective Awakenings, grower, processor, all the above, patient advocate.
And I'm Shirley Patton, and I am Andre's assistant.
And who do we have on the phone?
Tristan here, Tristan Reisfar. I'm clinic manager here of Mothers Against Misuse and Abuse in Bend. I'm advisor for the City of Bend's Police Department, amongst other little duties as well.
This is Todd Delato. I'm a horticultural scientist, president of CAN Consulting, and director of horticulture for Oregon Sun Farms here in Corvallis.
I'm PK. I'm a patient advocate. Mercy TV, a concerned citizen.
My name is Ben Magnus, and I am in the audience today. Great. So thank you so much for leading this, and thank all of you guys for all your hard work that you do.
Mike Rockland, I'm a cannabis nurse, RN, patient advocate, interested in workable regulations and legislation that I see happening. Thank you.
Fantastic. Thanks for being here. Okay, so we're going to start with the OHA administration report from Andre.
Okay, so I wanted to touch briefly on what we're going to do today for this meeting. So I don't know if it's the first time, but it's the first time that I've done this, is that the ACMM will actually serve as a rules advisory committee on rules that the agency is promulgating or changing and amending. So there's no need to vote on these rules. It's an advisory committee, so you can provide us with advice, any changes that you see fit, or thumbs up if you think the rules are good. And then we will take that advice and information, put it into a final draft, and then that draft of the rules will be put up for public comment later on in October. And that's when the public can actually comment on the rules, where we have an open forum, public meeting. So I guess it's important that we get through these rules today, because this is our only chance to meet on these rules before we have time to file them, and they're particularly time sensitive, and we want these to be effective November 29th. So for us to do everything we need to do to get them to the Secretary of State's office and filed, we just need to get through them. So we'll do that, and I apologize, I double scheduled, so at lunchtime I have a lunch presentation to the local public health administrators down the street at the Ambridge Center. So I'll politely excuse myself, make that presentation, then I'll be back after lunch. Margaret Lute, who is the operations and policy analyst and our rules coordinator, I'll leave you guys in her very capable hands as we review the rest of the rules if we don't get to them by the time I have to leave. Okay, so Shirley was kind enough to provide copies of the most recent snapshot. And there's just a few for July, so pretty up to date. We'll have probably August coming out in the next month or so. Just want to mention a few things. First of all, card applications are still pretty slow going. So we're at 58 days, which is not statutorily compliant. However, we do prioritize cancer patients, minor children, and HIV/AIDS patients, so they do get moved to the front of the line. And 58 days is the total time for complete and incomplete applications. About a third of our applications that we receive are incomplete or don't have discernible information, so that does pull back on time that applications are completed. Recently, we have decided that we're putting complete applications as a priority instead of mixing them all together in one package. And then incomplete applications are addressed at specific times in the week. In addition, we have hired temporary staff to help with the workload. So this is a 100% paper-based application, limited resources, so it just takes time to get through each application by hand and manually, which is a real problem and part of the reason for our backlog. That being said, we have invested resources and money in developing an online application that will be launched in January of 2017. So it'll be completely voluntary. The paper-based application will still be available for patients that don't have access to internet or just don't want to do it that way. But we're hoping that with some training and outreach to the community and to clinics that we can actually reduce wait times through the online application. So what we'll do, I don't know if it's going to be late December that the software will be finished, but of course there's bugs that need to be worked out and testing. I would like for ACMM members to take a look at this online application as it's in its beta mode.
Absolutely.
And we'll have you guys kind of test drive it a little bit. And if it's at a point where we can make some fixes that you guys noticed, then we'll do that. And then the plan is to launch it in January and then to make a tour of the state like we did for the reporting and tracking training, to do that for the online application, and with the goal of getting clinics on board with the online application, because I feel like that would really put a dent in card waiting time.
Absolutely. And Allegra, can the outreach committee work on this in tandem?
Yeah,
and really provide some support?
So that would be great if I'll get in touch with you a little bit on outreach.
Because I don't mind traveling.
And I'll be a part of that
clinics
too.
or anything like that either.
Yeah.
Please keep me in the loop on that one, Tristan here.
Okay.
Is there anybody else from the committee that would like to participate in that, assisting the outreach and the ACM?
What is entailed in that?
It's as Andre just explained, it is, the beta testing is one avenue. Another avenue is we have an outreach committee where we go out and we can outreach to the clinics that exist that provide the recommendations. And so it's communicating with them and also helping to educate them in this new resource that's about to come online. Okay.
Another update is that we had our first clinical guidelines work group committee meeting last week. So this is something that the legislature directed OHA to develop a clinical guidelines work group of physicians, DOs, and MDs in writing a report to the legislature recommending how physicians should recommend the use of marijuana to patients.
Okay.
So right now I think we have about there are about 6 or 7 physicians on this work group. They're a very diverse group of physicians and practitioners. So we have physicians that have no experience with cannabis, and we have physicians with a lot of experience with cannabis. We have clinicians in private practice, we have those in academia, public health, and then physicians that also work in clinics, cannabis clinics. So our next meeting will be probably at the end of September and October. They're public meetings, anybody can attend and observe. Probably another meeting before the holidays, and then we'll be drafting a report to the legislature that's due in January.
And where is the notice for those meetings posted on the Oregon Authority website? What division or department can you find that information?
You can find it, I think it's on the OMMP website.
Oh, okay.
You know, I know our website's pretty big, so it might have been
I know.
hidden. But we'll make sure that it's visible, and
Okay.
we could probably put it on the same page as the ACMM. I think will probably be the best idea.
Thank you.
And what are these physicians reporting on? Are they advocates, cannabis advocates?
No, not necessarily. So, for example, there is an anesthesiologist that also recommends cannabis to patients on a regular basis.
Mm-hmm.
We have a physician that works at the Compassionate Care Center. We also have physicians, a pediatrician that is in private clinical practice. We have a pediatric neurologist that is in private practice and also at OHSU. And we also have a public health physician.
And so they're writing their opinion of, I'm not clear
So
what they're reporting.
So what it is that the legislature asked this OHA developed this work group to say, what are some clinical recommendations for recommending marijuana? So one of the goals that this committee has, it's not necessarily setting a standard of practice, it's just writing a report saying, we recommend that here would be the standard of practice
Clinical
for physicians. Yes.
You are aware that the VA physicians are all afraid to write, aren't you?
Yes, I am. Even though the VA has recently issued guidance to their physicians saying it would be okay for them to recommend it.
They're mortified.
I know, they're mortified.
Okay.
So, you know, some of the goals, let's say, for this clinical work group would be to set a floor as far as clinical practice for physicians recommending the use of cannabis. But also they would want to say, well, here, you know, this is the minimum that you would have to do, but here's the ceiling, here's best practices. And also they would want to consider method of delivery, dosages, but they are going to be reliant on scientific evidence and evidence-based medicine, which we all know that's limited, so that would probably be in the report as well as an acknowledgement that there is limited evidence to support clinical practice. But also considering minor children that need cannabis for relief, so they would put that in the report. So we just had our first meeting, and it was kind of an overview of what they want to accomplish in the next 3 months. And then they'll get that report out to the legislature.
Awesome.
So any other questions? I mean, the stats are there for you guys to look at. We've had a decrease in patients, so we're at about 67,000. That's part in due to the fact that we are gradually decreasing out-of-state resident patients. So as they come up for renewal, we're just not allowing them to renew if they still are out of state, have an out-of-state residence. So that outside contingent will eventually decrease until 2017. Another reason for the patient decrease in these statistics is that of the 30-day backlog.
Right.
So those patients aren't showing up here in our statistics because we haven't processed them yet.
I have a couple comments, if I may. This is Bob Blake for Tristan and others. I did attend the clinical guidelines work group meeting last week, and I'm very interested in it. I would make the recommendation that we try not. There was the discussion about being punitive versus helpful, and I think what we need to do is make sure that patients can get recommendations to receive cards without making it overly difficult. I mean, we want to make sure that there's good clinical concepts and guidelines and premises, but I also think that you begin to get toward the punitive very quickly when you involve the medical board. And the physician community is absolutely very, very, the private sector physician community especially, just wants to stay as far away from the medical board as possible. For whatever reason, they're not doing anything wrong, but they've just seen the medical board pick people apart mercilessly. And so I would suggest that we try to stay away from asking too many opinions, because when I called the medical board about the cannabis subject, they say, we follow the statute, and I think we should leave it at that. I really do. I believe strongly that just leave it in the statute, and they really don't have much of a role. If we start involving them in, Andre, in having a greater role, I think we're gonna, all of us in the industry are being burdened by overregulation right now, and I think we run the risk of running off the very few doctors that we do have. So I would look at that with great care. The other thing is, on this patients by condition, some of your percentages are not correct. You'll have to redo that. You have 89% and then 29. Obviously, that's more.
Oh, that's it's cumulative. It's not cumulative. It's not mutually exclusive. So they can select multiple conditions.
Okay.
So yeah, it just kind of looks like it's supposedly cumulative.
Fair enough. Okay, I got it now.
Hey Bob, Tristan here. Thanks for bringing that up. I got to tell you, anytime I hear anything like that myself, being on the clinical side as well, particularly dealing with the population, you know, out here we handle an awful lot of Eastern Oregonians. I just get worried that once again we're going to be scaring off the few doctors we have left. So I appreciate you bringing that up.
Thank you.
And just to comment on that, the clinical work group, its purpose is not to be punitive. And so it has no affiliation with what the medical board does. I mean, we have, I think, one member from the medical board sitting on this clinical work group. And I think that's necessary because that,
I agree.
That would be representative of the community. But you know, there was a discussion at this meeting that those physicians also didn't want this to be a punitive style report. This is just informative for the legislature for good clinical practice. And there is statutory protection for physicians that do recommend marijuana to patients in Oregon law. So they cannot be disciplined by the board merely for the fact of recommending cannabis to their patients. Now, if there's other stuff that they're doing involved in that, then that's up to the board to pursue that. But OHA doesn't have any link or, you know, any sort of influence on that process.
I guess it's always the legislature I'm more worried about.
Good point, Tristan. Is there any more comments or feedback regarding the statistics? No? Okay, we can move on to the next item, which is the draft rules that go into effect. So let's get started.
Okay, so we'll have Shannon O'Connell will probably come in a little bit late to help us if we have any legal questions. But we could just start with the beginning. For those of you on the phone, Shirley probably emailed you this morning or last night, both.
Last night.
With the most recent drafts. They're not significant changes, and I'll just notify it once we get to a point that wasn't in the, or you guys let me know if you see something that you didn't look at before that's new that you don't particularly understand. Okay, so starting at the beginning here with 333-007-0010, which is the purpose. So what we've done here is we've basically just deleted the October 1st date. It's not, I mean, these rules are going to go into effect November 29th, so October 1st will have already passed, so it's just not necessary to have that in the rules anymore.
Okay. Why was November 29th chosen? Why that date?
That's the latest that we could actually file rules and have them effective before December 31st.
Because we have early sale rules that are temporary rules right now, and the temporary rules expire November 28th. So in order to extend those temporary rules for early sales to the end of the year, we have to make them permanent, and they have to be permanent by the 29th so that there's no gap.
That's the better answer.
Perfect. Great. Thank you for the explanation.
Okay, so on page 2, now we've gone into labeling requirements. So the purpose of this rule here, if you look at, it's 0090 subsection 4 little c, and then big A and big B. There were products that were too small to contain all the information that was required on labeling. So OHA would write to rule that you can have a peel back label or an accordion style label that can contain some of the information in 4B of that section. So you would still have to have the information on your product container that was the principal display and the warnings and the concentration in THC, but all the other stuff,
Nutritional facts.
Yeah.
Things like that.
That can be on a,
See on an
yes.
aspirin bottle that you peel.
Correct.
Okay.
Correct. So that just allows people with very small containers to additional space that, but still have the labeling, meet the labeling requirements.
Correct.
And then of course we reduced the font for that information. So the font was all set at 8 point for all information, but the information that we felt wasn't, I guess, the primary principal display information can be 6 point font, so a smaller font to accommodate those smaller containers.
The 6 point font is only allowed for the smaller containers, just to make that clear.
Okay.
It's
So
not
8
for all products across the board, it's just for the small containers. And then the required warnings still have to be an 8 point font.
Is there a definition in here, so forgive me if I'm, haven't read through everything. Is there a definition of what is a small container?
That is actually on sub 4, the beginning of that section. That goes into the small, well, sub 4 goes into the small containers, and it just says a container that because of its size does not have sufficient space for a label.
So it's open.
It's
Yeah.
open.
Okay.
Yeah.
Okay.
It's going to be a judgment call on the processor. And OHA will be pretty flexible with that. I mean, if the processor says it's, you know, something like this, then obviously we're going to say okay.
Right.
But if it's like this and they say it's too small, then we're going to
Yeah, for the
disagree.
labels
I mean,
this
we're not
big.
going to, we're going to be flexible but reasonable.
Okay.
Now, you guys are meeting OLCC because they're
Oh,
the ones.
we're coordinating with
We're
OLCC
coordinating.
on this, so they send us questions and we kind of go back and forth on it. So it is OLCC that does the label.
Just want to make sure because we're getting doubled everywhere else. I just want to make sure it's the same.
And then if you go to subset on the next page, page 3, if you go to subsection 15, so this deals with the extract cartridges specifically. So this is very specific to vape cartridges. So it basically says you don't have to have all the required labeling, but you must have that warning, keep out of reach of children.
On the actual
On
cartridge.
the actual cartridge,
itself.
yeah.
Okay.
So the actual cartridge doesn't have to have all the specific labeling. The package still does. But you know, once you take it out of the package, you put it in your vape pen, what's the point of having all that labeling?
Right.
Other than just, you know, we still want the child safety warning there.
So this is for both the symbol as well as the text
Yeah.
for reach children
Yes.
on the cartridge. Okay.
Did you have a question, Lyra?
No, I'm glad I don't have cartridges.
Oh, me too.
That's ridiculous.
So Shannon, we just got started.
Okay. Thanks for joining us.
Yeah, thanks.
Let's see, now we're on definitions.
Anji, may I ask, did you get consultation with processors who do vape pen cartridges? Just in my mind, it looks you know, cartridges are very, very, very small. So did you get some feedback on the logistics about how easy it would be to print that warning on such a small cartridge?
I think the way that we were notified of it is that cartridge manufacturers were applying for the labeling and packaging pre-approval through OLCC and had sent some pictures in of their cartridges and were questioning whether they needed to provide all of the labeling on the actual cartridge. And then the decision that we had, the discussion we had with OLCC, And then what we got back to the manufacturer was, no, we'll make a decision that you don't have to, but at a minimum, you have to have that safety warning and the warning for children. So there was a discussion with that manufacturer.
Right. Okay.
I mean, otherwise, if you have no labeling or warning whatsoever, you have basically an unidentified extract cartridge laying around that could potentially present some problems.
Right. Yeah. I could see, putting the universal symbol on there, and then getting into some text. I'm just wondering if the cartridge manufacturers feel like that's easy to comply with, or if there's another pictogram that we could come up with that equates to keep out of reach of children, or something that would be effective, but with a very small footprint on the product.
Any other comments on that?
Okay.
All right, thank you, Todd.
Sure.
So we're going back into definitions. So here we just deleted the October 1st date in subsection 6, and subsection 5, subsection 6, and made that date January 1st, 2017. If we want to go to retail marijuana item concentration and serving size limits, it's division 70210 on page 5.
What about capsules under that section?
What section are you referring to?
That 0210 item concentration and serving size. I guess it's table 1.
So how is that relating to capsules?
Does it apply here?
Retail marijuana item?
Or medical marijuana concentration limits? I've always questioned how capsules are considered.
Yeah, so what we've done here is it used to say, well, if it can't be capable of being scored because it's not solid at room temperature, so we've deleted because it's not solid at room temperature to leave that more of a judgment call on the processor as far as their ability to score a product.
Well, you can't score a capsule.
Right.
That's right.
So that now this rule, the way that we've edited it and amended it, would allow that capsule manufacturer to set that concentration and serving size limit in a different way rather than scoring it. So they would just have to basically label their bottle or package with what a serving size is. For example, 1 capsule is a serving size equals 5 milligrams.
Okay.
So this came about because we were getting all sorts of edible products like cupcakes that manufacturers didn't necessarily want to put lines through because they wanted to keep them nice looking and presentable. And they were kind of handcuffed by the fact that, well, the cupcake doesn't necessarily melt at room temperature, but we felt that, okay, we'll remove the temperature and the solid language and leave it more of a judgment call on the processor. And that applies both to retail and medical marijuana items.
Any other comments?
Okay, so purpose and effective date, we just delete the October 1st date here. So some editing. So now we're into overall definitions of Division 8. So here we've changed the definition of what a PRMG is under subsection 46 on page 11.
Can I ask a question about that?
Sure.
In some areas, isn't it referred as an MMRG or an MMGR? There on the website, NFPS.
Oh, that might just be the abbreviation for the registration number, but it has no legal or definitional bearing.
Okay,
MMPS is a medical marijuana processing site.
right.
And then MMG is a medical marijuana grower
Right.
registration, and then MMP is a dispensary registration number. So here we just make a delineation that a PRMG is someone that's registered by the authority. Not to be confused by a producer on the retail
Of
side.
the OLCC, right.
Right. I mean, in order to be considered a PRMG by the authority, you know, as it applies to this rule, you have to actually be registered. So, you know, not just be an applicant or have been designated by a patient, but you have to be registered by OHA.
Right.
Yeah.
Which is a separate number identification than your OMP number as a grower.
Patient.
And that's where you pay the extra $200.
Right.
Basically, to be a PRMG costs you an extra $200 now.
Everything costs you more now.
I understand, but I'm just
Like
trying
saying
to
wedding.
verify.
Now it's marijuana, you say marijuana.
Well, here it's, you know, a patient who identifies him or herself as a person responsible for a marijuana grow site. So that could be their own personal garden, but they wouldn't have to pay.
Correct.
So if you know, you can have up to 12 plants for you and your spouse at a household, considering your spouse is a patient as well, and you wouldn't have to pay.
Well, let's talk about that because we've received a lot of letters and emails in the mail and a lot of complaints on this subject. And we are now, this group is in a fairly public position. Granted, this is my first official meeting, but I've read this stuff and I'm concerned. I'm concerned that we've raised a lot of the prices, the costs, and and we're getting a lot of patients who are having great difficulty affording this. So we basically have a transition period going on where we have a lot of people who had, you might call in the industry, cards stacked, and now they're transitioning, the assumption is, to an OLCC licensed grow site. So the number of cards that will be registered as PRMGs, I think, will significantly decrease next year. So this might be a blip, but I think we really have a fragile population out there that are these patients who actually grow for themselves and need more than a small number of plants, particularly now that there are no more growers growing really as in the volume that we used to have with medical. So I would like to, this may not be the spot right here in this discussion, but I think it needs to come up at some point in our meeting today of how we're going to address these complaints that we've been receiving. And I heard you, Andre, say something about, well, you can have 12 plants if you and your wife are there. Can you just go over that again so I understand it more clearly?
Okay, so a situation where you would not have to pay to grow would be if you're growing for yourself at your own residence, and you can have up to 12 plants at that residence.
If you have a card.
Yes, of course, if you're a medical patient, and then a grower.
At your own residence.
At your own residence.
As soon as you take it to another location.
Then you have to pay, and as soon as you distribute it into the dispensary system, then yes, you have to pay. Or as soon as you have over 12 plants, then that would indicate that you would have to pay that fee.
Is it 12 plants because it's a husband and wife?
Because it's
here,
a household.
or a household.
Husband, wife, husband, husband, wife, and wife.
So you're allowed to
brothers,
have 12
sisters.
per household?
At that, yes, at that residence.
You're saying if they're both, you're saying so
It-
if both
As
long as there's
husband-
two card holders
Yes.
there.
Yes.
Right,
If there
so
are two
husband
card
and
holders.
wife, both patients, both growing for themselves at their residence, right, 6 each. And in fact, at that household, you could have an additional 4 under Measure 91.
You could?
Yeah,
So you technically could have 16 plants.
24.
if you have two card holders.
So, yeah.
16 mature plants, let's even be more specific.
Yes.
16 plants in flower.
Yes.
You could have an unlimited number of plants not in flower.
Theoretically, yes.
Theoretically. Theoretically.
Yes.
Am I-
Yeah, so you have 2 card
I want to be
holders.
very clear for the record here because
Yes.
we're going to get hammered on these points.
Well, it's pretty, it's not that complicated.
I agree. That's why I want to
But
make sure.
But I want people to understand that I think that people need to get their own individual legal advice about the immature plant issue. I think the Oregon Health Authority has been clear that it's not going to enforce any limit on immature plants. How law enforcement is going to view that is entirely another matter.
Yeah. Thanks.
Yeah.
And if you don't have them specifically separated or tagged as flowering or veg, they will also do whatever they want.
Right.
They will tell you that that's not flowering. So you really want to watch your P's and Q's.
Right. And then in the extent of law enforcement inquiry, they will call us
They do.
and they will say, we're at this residence. A, is it a grow site? We can say yes or no. And then we can tell them how many plants, mature plants they can have at that grow site. And that's all the information we provide them. So Bob, going back to your question.
Yes,
As
sir.
long as you have 2 card holders in that household, whatever their relationship, it doesn't matter. They can have 12 medical plants, and then there are 4 additional retail, rec, whatever we want to call it, adult use plants. Per card? No, it's just per household. Per household.
Yeah.
And they would not have to pay a grower fee.
I think, Andre, when we answered one of the gentlemen who wrote into us, or wrote into me, or I responded, I don't know. I don't know where it came from, whether it came through the general ACMM mail or whatnot, but I responded to the gentleman. And I think this response was acceptable. I think 16 plants in flower will produce quite a bit for an individual patient.
2 patients.
Or 2 patients.
What happens if there's 3 or 4 patients on the same resident and have a separate card?
Yes, and then they would also have to pay the grow site fee. So once you,
But they're
Justin
living
here.
there.
My concern once again is this sounds all great with plant limits, but they're still going to end up with no doubt more than 1.5 pounds of dry usable herb themselves, and they're going to be more than likely out of compliance from that end. So let's not forget about the amount of dry usable that's currently allowed for these folks.
so Madam Chair, I think this is a good conversation. I think we need to have this conversation, but if we could table the conversation until after we get through the
I
whole
agree,
discussion.
I just brought it up because it hit this point and I didn't want to forget.
And then,
Thank you, Andre.
Thank you.
okay, so we'll
Keep on going.
We'll get on. But no, good conversation, and I'm glad that we need to have it and kind of bring it out. Okay, so page 13, I'm on Division 80023. This is the patient application review process. So if we look at subsection 2, the change here is the authority can reject an application as incomplete if they don't provide us the minimum requirements for that application. Otherwise, we would notify the applicant, which we currently do now. We either do it by phone call, email, or primarily the letter, and then give them 14 days to submit any missing information. So the reason for this rule here is that since the legislature mandated that we issue receipts, we have been receiving severely incomplete applications. People have put in advertising flyers into an envelope and sent it to us with a return receipt, a U.S. mail return receipt, in the hopes that we would issue them a receipt for 30 days to have access to medical marijuana. So we see this a lot. Or we see something where, let's say, full payment is required of $200. People will send in a nominal fee and then expect to have a receipt or an application processed after that. So what we want to do here is that if you don't provide us with the application, the payment, the government ID, and the APS, we can basically say, we're sending this back to you, try again. Now, if there's other information, whether it's like a minor patient and we need the parent's signature, if there's a growth site information, caregiver information, if we don't receive that, then we're saying, okay, we received your application, we'll issue a receipt, and now you got 14 days to get us back that additional information regarding caregiver, parent guardian, or grower. So we felt that this would be kind of a fair way that the authority can get through applications faster, a fair way that we could process applications for people that have taken the time and consideration to send us a complete application, but still allow for some corrections if there is missing information.
Sorry, you guys have to deal with that.
No, I mean it's a significant reason why we have a 28-day backlog. We just received about a third of our applications are just severely deficient, and we have to notify them and give them 14 days, and then send a mail out, and it just it takes away from the people that are actually doing what they need to do to get a patient card. Okay, so annual renewal on the next page. So this is a rule that implements the legislative mandate from this session, saying that if you have a 100% total disability rating as a result of your service, then you do not have to get an APS every single year.
What does it go to?
So those veterans would still have to apply and pay the fee, $20 fee for all veterans, but they don't have to go to a physician, because the concern was they go to the VA clinic, the VA doctor says, I don't want to even deal with this. The veteran then has to go to some other physician, pay out-of-pocket expenses for the exam, and then do this year after year after year, even though the VA has told them that they're 100% disabled. And so legislature just made this law, and we're just implementing it.
And when is that going to take effect?
So these rules take effect November 29th.
Thank you.
Everything going the way it needs to go with the rule review and public comment.
Except 0600, it remains October 1,
Yeah.
labeling, packaging, and testing.
Right. So,
That's based on what succeeds.
right. So before, previously in our last permanent rule iteration, we set a deadline for October 1 for stuff that needs to be labeled, packaged, and tested accordingly by the new rules. That still remains the fact. And we'll get into, there's some other caveats to that and some exceptions, and we'll get into that a little bit later. Okay, so what we have in page 16, subsection 8A, related to a dispensary registration. So if they don't provide the information in subsection 3, then we'll give the applicant, the dispensary applicant, 10 calendar days to provide us the additional documentation for that application.
As opposed to rejecting the application in prior years.
Yeah. Well, yes.
Okay.
How is that division going? Is it getting better? Turnaround time?
Yeah, I mean it's about 3 months on average, and a lot of it depends on the dispensary. We send out the readiness letter. Pardon?
Because it took us 7 months to get our renewal.
Renewals are a little different.
February already.
Right, and as long as you get your renewal application before your expiration date, you can continue to operate as you have been.
Okay.
So that really isn't affecting renewals that
That's
much.
when you just a big scare between managers and things like that when they see that we're expired and I'm trying to explain to them we've applied. And
Yep. Yes,
Just
so
wanna make
that's,
sure-
that's still okay, as long as you get your renewal application in before your actual expiration date.
Always.
The rule previously said, no sooner than 90 days before and no later than 30 days or 60 days, I can't
Yeah,
really
it is.
remember. Now we've just said, just get it in before the expiration date and you can continue to operate. Otherwise, if you don't get it in before your expiration date, like anything else, driver's license, you can't operate legally. Okay, so now we're into more dispensaries, so it's page 18, limited access areas.
I have one question on page 17.
Yes.
It came up with a question on somebody. A public, I guess, the definition of a school is under Oregon law, correct? We're using the Oregon statute to define what a private, public, or elementary school or whatnot is that correct, Shannon? I mean, daycare centers or different things to say, I'm teaching kids are not necessarily covered under this.
No, it's K through 12.
K through 12.
Yeah. And
Okay.
it has to be a combination. I think it's not just kindergarten alone. It has to be kindergarten in combination with some other grade.
But it has to be under Oregon law, a registered sort of facility under.
Not registered, because private schools and things like that are not actually required to be registered or anything with the Department of Education anymore. So, I mean, public schools is sort of an easy one. I mean, it can be challenging sometimes to determine what is a school and what's not, so there's sort of criteria that we apply. But if it's a place where, under Oregon law, your child would be considered to be getting credits because kids are required to be in school, then it would be a school, but of course not if you're just homeschooling.
Yeah, I remember it was.
Hey, remember, Bob, here in the city of Bend, the city added daycare centers. It's not a state thing.
Right.
Any other questions on the schools? Okay, back to page 18, limited access areas. It's a change of language. Here we delete point of sale and make it clear that it's a limited access area that the public cannot have access to.
Yeah, that seems problematic to me in that it's too limiting of a unique kind of commercial space.
Are you talking about the requirement that there be a floor-to-ceiling wall?
I'm talking about 16, subsection 16.
We're still on subsection 11.
Oh, okay, sorry.
We'll get there.
Okay.
So it basically requires a floor-to-ceiling wall that prevents physical access between the limited access area in the dispensary and the area that's open to the general public. But if you look at subsection B, you can write us for an exception to that floor-to-ceiling wall. And we've actually gone into several dispensaries where we've noticed that if it's in an old warehouse in Northwest or the Pearl District, they have 20-foot ceilings. So obviously it's not practical to have a floor-to-ceiling wall. But if you have a separation barrier that's at least, let's say, 9 to 10 feet, okay, it's going to be hard for a burglar to scale that, get into the limited access area, steal your product. So I mean, it's not a requirement that's set in stone, and we would evaluate it on a case-by-case basis. And we have provided exceptions for dispensaries that have these borders that do not go to the ceiling.
Well, I can think of a couple of dispensaries where there's I don't know what we can do here, but I can think of a couple of dispensaries where you have a what do you call it, reception desk, and you can see, you can't see into anything, but there's safes and everything behind there. So it's not floor to ceiling. In other words, you could jump over the reception desk.
You still have to have some sort of door to the access area.
Yeah, then we would, what dispensaries are these?
Yeah, you can't get in, it's supposed to be access.
I'm just kidding, we'll get to them.
All right, well, I can think of one or two.
Oh, there's a lot of places not doing these, right? That's
Okay,
okay.
well, you know, if you are in public record, so if you do let us know a violation, we're now aware of it, so. If
No,
you want
I-
to tell me in private, that's fine, or if you
No,
want
I
to keep
just
it to
could
yourself.
think of
we'll get
some,
to it.
yeah, all right, that's fine, no, I'm just wanting to know.
Okay. Same thing here with subsection 14, so point of sale area is the same situation. Floor to ceiling wall, but you can request to have an exception. Just give us some pictures, a description, and alternative barrier that would accomplish the goal of providing a significant physical barrier between the general public and where any marijuana items are on the premises. So same situation, but just for the point of sale area. Okay, so
Skip over 13.
did I go over 13?
Yeah.
Okay, so 13, subsection 13, we want a scaled floor plan now, rather than a sketch. This is because we've gotten all sorts of pictures of places. I mean, there's software that does this, you know, you could pay, you know, $100 so and get like a drafter to do it. I mean, it's not hard to get a scaled or blueprint of your facility. Just, no crayons, please. And then 16, we can have this discussion now, Todd. So, you know, this is a situation that we're confronted with not often, but sometimes, where dispensaries will, let's say, lease an old Victorian style house, and they reside in part of it, and then they have their dispensary in another part of it, and there's really no, you know, physical barrier that doesn't have ingress and egress. So there's always going to be a door somewhere. So here we're basically prohibiting residential occupancy on the dispensary premises.
Or I think there was a situation where a dispensary was maybe allowing a PRF for somebody to live in the.
Familiar of one that I've heard of that.
And this is something other than like a multi-use apartment building where there's obviously a physical barrier between the store on the first floor and the apartments on the second or third floor, whatever. I mean, this is kind of leaving it open for you guys' discussion. We haven't really come to a decision on this rule. I mean, the reality of this situation is evident. I mean, we're open to alternatives.
This is Todd here. The you know, residential occupancy of a dispensary premises. I mean, that sounds like a no-brainer. It seems like that's already prohibited. But what concerns me is when you have unique commercial spaces, like shopping malls, for instance. You know, I'm looking at the language in 16 above the residential part.
Right.
You know, that would, you know, prohibit a dispensary from being located in a shopping mall type of situation, you know, where there's kind of a common space of other businesses, and it just seems the way it's worded is rather limiting to a lot of situations I could think of. And I'm not really sure what communication of space means. So maybe if you could explain the intent behind that, I could understand a little better.
So could I piggyback on that and discuss if, there was a multi-unit facility and there is a hallway where there's a restroom that is commonly used by all of the tenants. Would that?
But you'd have to go out of the dispensary, right, into a common space, and then go into the restroom. That's not what we're talking about, huh?
Not always, sometimes it's limited access areas
Right.
that have, the back door of that limited access area is the shared hallway that leads
Yeah, so I think that's kind of the situation
Well,
with Todd's example is that.
One of the things, Tristan, here, that at least I've been involved with in the city of Bend is actually always in this urban growth boundary issue here. And it's always a discussion of we grow out or grow up. And basically right now we've been growing up. And so the city here actually encourages a lot of businesses to have homes with them. And we've got actually little development areas here in Bend where specifically those buildings exist for that very reason. And so just from a zoning standpoint, I know it has nothing to do with us really, but I just thought the conversation should be urged or anyway, and maybe discuss it. You know, our city would actually encourage that to happen here in Bend. So just maybe a little different way of looking at it over here.
So here's kind of what we've been discussing internally. The purpose of this rule is to prevent theft and diversion, right? So we don't want someone sneaking in the back door from the adjoining space and pulling supply out, or for some reason that being an avenue, a physical avenue for diversion. So, you know, does it matter that that it has to be a wall with no door and no windows? Because that's basically what no communication of space is saying here. Or if you're going to meet the intent of preventing diversion and theft is, well, then you need a locked door that remains locked at all times, and then you have cameras at ingress and egress.
Those are already required.
Right, but not for the separate facility, but not for facilities that share spaces.
But you're still supposed to have cameras on the outside and inside on every entry and exit.
But they don't necessarily do in these situations.
That's the other, I mean, the residential piece, you know, someone living in the same space, the security camera coverage is actually one of the issues. I mean, it creates a real privacy.
I could definitely see it in the residential, but I've been to a bench shop. A friend of mine has a dispensary there, and he's separate. He's got like 4 bars around him, and you know, it's like this whole thing. They all share one bathroom. So I mean,
So that you could,
they'll have a hallway
so you could exit the dispensary.
into
you
the
would
hallway.
Need, right, but you mean you need a key to get back in, right? I mean, it's not.
He's got one of the, yeah, it's a push
Right.
door, yeah. So that, I could definitely see that, like,
So, I mean, we're not-
they share
yeah.
the subway and the pizza place, they share a hallway, so I could definitely see.
And as an agency, we're not stuck on this rule. That's why we're
Yeah,
asking
no,
you guys'
this is
advice.
great.
Is like,
Glad we
what's the better
discussed it.
solution here? I don't know if you want to recognize members of the audience or not.
Yes, Ben Magnus.
Sorry, I just would like to thank you guys for indulging me, but I would say as a classic example, where we have a commercial, when you start taking the zoning, I'd recommend that you take the industrial, have the residential be a no-go, right? Like you have the same word, but get rid of the industrial or other commercial. As an example, if you have a dispensary that wants to take advantage of selling CBD-only products that are not allowed in the dispensary, you have to have a separate area for it. It's a separate area for selling lighters or anything else that's non-dispensary related paraphernalia. That creates a separate retail environment. You've now created a separate store. By the nature that, you know, that's commercial, that's a separate endeavor. You walk in to your front reception area, you have your CBD ointments and things that aren't qualified, you have your chewing gum and stuff. Then you walk into your dispensary. By the definition of this, that would not be allowed.
You would have to walk outside the building and come in through
It
the
would
front
be,
door.
and so I would say that the nature of commercial structure, being in real estate my whole life, and specifically commercial, this would affect detrimentally many dispensaries. And I think it's an unintentional consequence that may come up. And I think that it would also guarantee taking advantage by the local municipalities that didn't want to see dispensaries, wanted to sort of, for lack of a better word, you know, start redlining areas.
So here's my proposal to adjust this rule a little bit. I'm sure Shannon can tell me later if I'm off base. Is that the requirement be that the occupancy or tenant space must be completely separate, but with a locked door at all times, only accessible to employees of the dispensary? Does that make sense?
Yeah, get rid of commercial and the other things, yeah.
I think the only other question is whether or not you know, you sort of wanna keep the wording the way it is for residential and make a distinction between residential and other sort of commercial.
Other
Because I can understand that, making them walk out their front door to go to their side door. I mean,
Yeah.
Or if
Probably
you have a,
doesn't know.
yeah, or if you have a situation where a processor and a dispensary are on the same property, but it's owned by the same entity, and of course, so if you want to take you're making, I don't, you know, brownies at your processing site, you also own a dispensary next door. Is it practical for you to take your brownies, go outside on the sidewalk, come in through the front door, or through the limited access area in the back to deliver it when it's your own business? So, yeah, sure, there could be a door there between the two facilities, but it's limited access, public prevented from accessing. Okay. So we keep the residential.
Here's my side of question on this whole thing. So we have a dispensary here in town that's located in the middle of a large structure of many businesses, and it's all on private property, and to get onto it, it's basically in a courtyard area that is, I guess, technically outdoors. How would a facility like that be affected? The other, you know, they have a common bathroom out there. There's a brewery in there, a theater, and what have you. So there's quite a few diverse businesses.
He's a good guy.
Do they have a back door, like a limited access area through the back for deliveries and?
I think everything comes through the front door.
I mean, I couldn't answer that question without seeing a floor plan or seeing it physically.
Okay, because I think that business may be affected by this rule.
Okay, well, we can change it and make it a little bit more flexible for the industrial commercial use access. Okay, next rule, Division 8, 1190, testing, just deleted the entire rule. It's not necessary because we have Division 7 testing rules now. So, 3 pages of regulation gone. Not really, still there. Okay, 1200, operation of dispensaries. Okay, if we want to go down to subsection 7, this deals with testing specifically. Deleted October 1st in subsection 7 because it's not necessary to have that anymore. So what 7B says, dispensary may not transfer a marijuana item that has not been tested unless it was transferred before October 1st and then labeled appropriately. Just getting into trying to make sure people understand that October 1st is the day for testing and labeling. Same thing for package and labeling. And then in subsection 9, which I think people will be happy about, is we've removed the October 1st date for the licensure by ODA for a dispensary. So they can continue to sell those food products in their dispensaries after October 1st.
When does that take effect? 1/1?
Yeah.
Okay.
So we're giving people 3 months.
Good, because the ODA just sent us their stuff yesterday.
Yes.
They're just now coming
Right,
around.
and we're in talks with the ODA to coordinate that.
Everybody's on waiting game.
Yeah. Next rule, 1225 packaging. It's not necessary. It's taken care of by the OLCC rule. Delete that entire rule there.
Yeah, Andre?
Yes.
Sorry. This sub 9 probably needs to say on and after January 1st, 2017. We didn't put in a date,
Okay.
so we'll have to do that.
Thank you.
Otherwise, it would be required.
Yes. So what Shannon said, for those of you following along, going back to subsection 9 on page 22, we did cross out October 1st, but we should probably indicate that it's January 1st, 2017. Otherwise, that rule would be in effect November 29th. Okay, transfers to a dispensary, pages 23 and 24, Division 8, 12, 30. Deleting October 1st there. Transfer records will provide a form for that to happen, similar to the authorization to transfer form.
For transferring products? Are we
So,
gonna do
so,
24?
so when dispensaries transfer to other dispensaries,
Oh, I see.
we just want like a form,
Manifest.
yeah, similar.
That's the way.
This is Todd. Can we go back real quick to nonprofit dispensaries? I just had one question on that.
Sure, where are you at, Todd?
Well, that's a little
Sure, on the
ahead.
nonprofit.
We're not.
We're not there yet.
You're ahead of us.
Oh, okay. I thought you were on 23. Okay, sorry. Go ahead.
Is there any place that we can see all these forms? Being new, I mean, I would like to see what you guys have.
Yeah, so if you go to our website, there is, and you're on the main page, there's a forms link.
Okay.
And there's forms for patients, growers, dispensaries, processors. And some of them are still in development, and you have to go through publications, but we put them all online.
And the medical marijuana
Yes.
program site.
Yes.
Would this form manifest from dispensary to dispensary be a one-time form annual, or is it for every single individual transaction transferring?
Dispensary to dispensary?
Isn't that what we?
So we're at transfer records, subsection 4.
Dispensaries can transfer to dispensaries.
Yeah.
Well, okay, sorry.
Transfer, or you
Sorry,
know,
to a dispensary, the dispensary registrant must document on a form prescribed by the authority.
Yeah,
That's
it's
my
for
mistake.
every transfer.
It's for every transfer.
transfers to a dispensary.
Yeah,
Yeah.
sorry.
So we're prescribing a form because a lot of documentation that we see in the field is somebody pulling out a scratch piece of paper, writing down what they got, and then putting it somewhere. And then when we come in to review transfer records, it's like, okay, well, what did you bring in? And they go and find the scratch piece of paper. And they're like, I think it's this.
I thought we were
Like,
having
nobody's
transfer
consistent
form.
about how they're recording this information. A lot of it's just chicken scratch on whatever they can find at the time.
But they have to have an electronic data management system which talks about their inventory, because they can't have more than 5%, and there has to be a transfer authorization form.
Right,
And
this is
the
like a
intake.
receipt, when somebody comes in, like a processor comes to a dispensary, there's that exchange that happens of, yes, I'm now buying your products.
I
And
thought
there's
that's what the
information
finished
has to
product
be
intake form
documented.
Yeah, and the voluntary, so like the voluntary
The intake form. like
intake
that you have to
forms,
Fill out with all the
or
testers.
they're gonna become mandatory. Understood,
Oh, I
okay.
thought they were.
No, they're voluntary, right, at this point, okay.
Thank you,
Well, we
Margaret.
make all of our food.
And then we added under big F the harvest or process lot number. And this is in case the product, if it's adulterated in any form or mislabeled, we can trace it back because we don't have metric. If we had seed to sale tracking, we wouldn't have to have this process. We don't.
Where is this?
If you just page 25 at the top, page F, so the form just has to document harvest or process lot number.
I'd like to call an audience member. Sure. Anthony?
I had a question on sub G, the amount of reimbursement paid. Is reimbursement even relevant now? I mean, they're not just reimbursing somebody under that reimbursement scheme that was in place for so long. You're only allowed to meet your costs. But now you can charge for everything. So it's not really a reimbursement system anymore.
Thank you, Anthony.
So, thank you for.
Yeah, that's a good point. Very good point.
I'm gonna look and see what the statute says.
Okay.
Thanks, Shannon.
And then if we look at, we deleted little b subsection E. Deleted deleted that because the producer and the processor have to get the item tested. And then deleted October 1st date here again. Not necessary. Okay. Now we are down to Division 8, 1250 nonprofit dispensaries.
Todd, did you have
Yes,
some
yeah. Now we can take
comments
specific
regarding
questions
the
on this.
nonprofit?
Sure. Down in 2E, I was just wondering if annual income at or below the federal poverty guidelines will be the kind of the primary criteria, because perhaps this nonprofit dispensaries would have other criteria for which they would give away cannabis. Such as someone who's not below the poverty line, but just, suffered, a major injury and they don't, they don't have, situations like that where income isn't really the important criteria of a person's situation, like they're a veteran or something.
Shannon, was that statutory?
Yeah, that language is statutory. I mean, there's nothing.
I guess that was a surprise to me as well. That almost seems like it's somewhat less likely for folks to want to get into the nonprofit dispensary side of things if your clientele is limited, and it always just seemed natural if you're paying the state fees. You should be able to access these dispensaries, whether they're nonprofit or not, because here in the city of Bend, we won't have any medical marijuana dispensaries next year at this time as things stand. So anyway, that was a surprise to me. It's statutory. I guess it's something we can talk with the legislature about.
I mean, this is Shannon. I mean, there's nothing that prevents a dispensary from deciding to provide marijuana at a reduced cost or free to anyone. I mean, it's so taxing is not an issue. So I think it's totally up to the dispensaries how they want to deal with that. I haven't viewed this as if you are a nonprofit dispensary sort of under this model that's the only thing that you can do. I mean, I think that you can be. I mean, you have to be incorporated as a nonprofit, but you can operate sort of as a regular dispensary, but part of your business is also sort of offering this other way of people being able to access marijuana. So
Could we add additional language to that?
People have horrible copays for their chemotherapy and their other drugs. And they could have a huge income, but they don't have money to spend, on paying their electricity bills, their other meds.
we can say that that nothing in this rule prevents a dispensary from deciding to provide cannabis at a reduced rate or free to anyone that meets criteria that the dispensary chooses. If that
I think it would be, go ahead. I think anything that provides more comfort for anybody to provide discounted and approval, I think is helpful, Shannon. If you can put more verbiage in, it would be good.
And maybe I'm right, I think it might be under the OLCC laws, but there is something stating that you can't transfer to a patient which needs to sell the product for less than the purchase price. There's like something in there that...
Yeah, I mean, this is medical only. This is not going to
No,
apply.
that's what I'm wanting to
OLCC
ask, is
facilities.
that going to be something that you guys, so you're just saying that no matter what purchase price or anything, there's not going to be, so we can do it as a reduced? Because we're
Right.
trying to decide whether to stay medical or not, because at this point, there's no point in it. If I can still sell to medical patients, it's a rec shop. So this is where I'm trying to figure out what is the best solution to help these medical patients, because that's why we're here.
Right, so this nonprofit dispensary thing right now only applies if you're on the medical side, not if you're on the OLCC side. you know, I think that it's the case that since medical grade marijuana is not gonna be taxed by OLCC retailers, that there's not gonna be any sort of prohibition on selling at the reduced price, but, I mean, that's a good question. Whether or not there's anything in the OLCC rules for medical grade that. Yeah, there is something in there about about discounts and things.
Yeah.
I'll,
Because I know we have to be careful, like raffle or free, just giving it away, there's still, I know like on the premises, you know, there's like.
yeah, I
Trying
think
to
that's
remember.
only gonna be rec
Okay.
campus, but I'll talk to OLCC.
Just because so much is crossing, I want to make sure we're doing the right thing.
I'd like to call on some audience members. You had your hand up for a moment. What's your name? Lauren Terry. Lauren?
There are those of us that actually cringe with the thought of the Liquor Control Commission, you know, controlling medicine. So I had a completely different vision of the way it would work myself, as far as a standalone co-op, maybe style, nonprofit dispensary. But we'll see how it goes, I guess.
Thanks, Tristan. Laura?
I would say that I think local law enforcement, in some cases, in my experience, we had vandalism on our farm and we just wanted to make a police report so we could get insurance to help pay for the shed that got burned down. And because that local law enforcement was under the impression that we have to be nonprofits by default, they were under the impression that to be a medical grower, you must be nonprofit and can never charge. So that theoretically they were saying, well, you guys better not be making any money or else you shouldn't be out here. And so I would say if we are going to change the wording, it would be helpful to say that although dispensaries can be nonprofits, they are not by default they don't have to be. Going back to what he said, the confusion around the word reimbursement rather than payment or however you want to word it. Reimbursement does make it sound like you are in trouble if you have money in the bank, but a lot of that is because you need to have money somewhere. But we felt less safe talking to the local police because of the way they had interpreted our laws.
Thank you. Ben?
Oh, I was just gonna concur with both of you guys and say from city and lots of previous meetings, but we'll see that you won't, a grower won't be able to go into an OLCC dispensary and give medicine or charge very subdued, say here, I'm gonna give you a pound and here's a couple ounces to give out to those who need. That can no longer occur under the OLCC rules. And so now it's happening with the medical league, the dispensaries are going away, basically, on the medical side for this reason. There really won't be, there isn't a nonprofit model for the OLCC, there really won't be much of a nonprofit ability. There won't even be the ability, if it goes where it looks like it's going, for medical patients to receive reduced or free medicine by statute.
There are
It
still-
doesn't prevent you from being a medical, even though it doesn't prevent you from staying in medical, most people won't be able to stay in medical dispensers and be viable, so they'll switch over. And so this only occurs, the problem is that from a delivery mechanism, because the rec will be able to sell both. The problem is, practicality-wise, you won't have anybody take advantage of it. And on where all the shops will exist on the rec level, they physically will be against the law to take advantage of it. It seems like that maybe that wasn't the intent overall, and I know that there is a way, there's ways to change some of the nonprofit and allow, I think on the grower side, the key is to allow gifting. And both medically and recreationally. And I know that's outside of our scope, but I'm very concerned about how it will work. In fact, I don't know how on the recreational side.
So, I mean, I think OHA is providing the mechanism to allow for these types of dispensaries to exist, and it's going to be market forces that.
And that's what I'm saying.
People are going to have to make decisions based on what they want to do personally and economically.
And that's what I'm saying. The more we can make this less rule rate, the more we can reduce the regulation, and the more we can reduce what we're requiring. I get if this is all in statute, and I'm quiet already. You know, I mean, is every piece of this just pulled from statute? There's no way to change any of this.
No, what we're looking at here, if you look at these rules, most of it is just that we want whatever's given away or transferred to be recorded. So that's kind of what the rules here elicit. And then, of course, the statutory requirement that about below the poverty limit, whatever. That's full drafting.
So can I point something out? So two things. One, I mean, I don't actually think that this legislation was necessary at all, because I think the dispensaries can do this now. The only thing that it does allow is it allows OLCC producers or processors to provide products to the medical side, which is something that otherwise isn't going to be allowed. I'm looking at OLCC's rules, and it specifically says that retail sale of marijuana for medical purposes, that those retailers can sell or provide marijuana items free of charge or at a discounted price to patients and caregivers.
So free of charge. In other words, we can, if you're a retailer, you can give it away.
To patients
medical patients.
or,
Medical
or
patients.
their
So that's
caregivers.
a
Really? That's,
See that?
I would prefer that. Thank you.
Yeah.
I
But
thought
it's-
that's what it did say too.
That was my motion. Thank you so much.
That clears up a lot for a lot of people.
Thank you so much.
So this time Andre has to step to his next meeting, so we'll see him after lunch.
Yeah, after lunch. I'll let Margaret guide the rules here.
Bring us back
All right,
up.
thanks, guys. I'm not eating lunch. I used to talk to people that are eating lunch. Yeah. See you
Just sit there
guys.
and drool
Thanks,
over
Andre.
Yeah, you'll be hungry.
Thank you.
Was there anything else about the nonprofit section that the members would like to discuss?
I thought it was free of charge. I thought
I
it
just
was.
remember you saying it.
You know, as of
Thank you
next
for
year,
bringing that up.
there'll be no medical marijuana dispensary.
Say that again?
He said, well, I heard him say, as of next year in Bend, was that what he was saying, in Bend, there will be no medical marijuana?
I think based on the
dispensaries?
trend, Bob, you could probably figure that. Tristan,
Well, I
right?
can tell you, I don't know of one that will stay medical in Bend, including mine or ours.
Yeah, I've had none say they were staying medical at all. So everything, I think we've got 17 right now licensed that are operating, and they're all going to go onto the liquor control side here.
So I think for clarification purposes, we can discuss it after lunch, after we get through this, but expanded access is the other side of the coin from early sales. So it was early sales to 12/31/2016 in the OHA realm. Now after 12/31 or beginning 1/1/2017, it will become expanded access. So you can expand sales to medical patients in the recreational facility. That's what we spent a lot of time in the legislature discussing back in February. So essentially it's the same as we have right now, just under different regulatory management.
So what we're saying is there's not going to be purely medical there. It'll be medical and recreational?
It will be one, it will be,
There'll be one that will be able to provide to the other, just like it is now,
Exactly.
but just
Okay.
splitting each
Oh,
other.
that's fine. I just need that clarification.
and I think that the fallout of this from a policy perspective and from a patient, if we're concerned about patient advocacy here, historically, we're going to probably see fewer and fewer larger medical grow operations. It used to be that a medical grow would provide an ounce or something to a patient every month for their card. That will disappear. You will see small medical grows in like homes or whatever with these 12 or 16 or 10 plants, and I think that's basically what's going to happen. But there'll be a whole lot of medical growers who are not going to, they're in the wrong county, they're in the wrong zoning, they're in the wrong, it's just going to be very, very difficult to get compliant. So you're going to have medical growers without many access points to sell their product to. And that is going to be, I fought very hard for the small medical grower in the legislative session, and I think the small medical grower is probably a dying animal.
But they can still sell to the recreational market.
No.
No?
No. I think it's a closed loop system.
I thought if they got a wholesaler's license, they would.
No.
Can we continue with the rules, because it's almost lunchtime?
Yeah.
And we've got like
I know,
20
you're
pages
right.
left.
You're right. Well, no, it's not so bad. We only have 15.
Unless you don't want lunch, then it's up to you.
Go ahead, Margaret.
Go ahead,
Okay.
Margaret.
Is there any other comments on the nonprofit dispensaries? No? So to move on to limited marijuana retail sales, as mentioned at the beginning of the meeting, this is to adopt these temporary rules to make them permanent through the end of the year. There are some minor changes within early retail sales. That would be
So you just got 5 pages.
page 28, clarifying the definition of a pre-filled receptacle of cannabinoid extract. We're taking the word cartridge out because that caused a lot of confusion, and just stating the word receptacle to clarify it.
Well, because you could have a syringe or something like that. Is that the point there?
You could have it in a container, you can have it in whatever. It doesn't have to
Okay.
be just like a big
Fair enough.
cartridge. It could be a receptacle of an extract.
Okay.
Page 29, sorry. Is it- Okay, trying to see what the,
Probably just taking out a space or something.
yeah, it's probably just taking out a space on sub D of subsection 12. And then down towards the bottom, again, just removing, the dates, because it won't matter at that point. And then page 30 at the top, it's just adding language, or rule references, statute references, at the bottom of 1500. Moving on to 1505, it looks like it's just a punctuation correction. Let's see. So as we move into the processor section, you're going to see a lot of the same changes that were made in the dispensary application process. So this is going to be fairly quick to go through. It's basically making the same changes of what documents are going to be required and what the process is going to look like. So on page 32, where it says documents required under sub 3, it's the same thing we mentioned earlier in regards to dispensaries, just for processors. Page 33 is also similar in clarifying language for processors to mimic what it said for dispensaries with limited access area, and also the residential and shared space issue, which will, whatever we do on the dispensary side, will copy over to the processor side. So we already had that discussion. Page 34, same thing at the very top about residential occupancy at a processing site. Page 35, sub 9 for 1740. It's just updating language and dates as we talked about earlier with processor or with dispensaries. So no major changes there. Page 34, same thing for processors. There's going to be a form, an intake form, like we talked about for dispensaries. It's the same thing, just for processors, for when they're doing from processor to processor transfers, or the patient caregiver grower transfers to a processing site.
We discussed this. Shannon, clarify this again. I haven't read this in this particular section. I probably should have in more detail. The current processor industry is, I think, going to change, because right now a grower will come to a processor and say, hey, process, and this is all in the quasi, legal world. It's not being regulated right now. So the processor will do a split. Remember, we had this discussion about a split. Is there any contemplation in any of this with splits at all? No. So basically, a grower goes to a processor, the processor either buys the material, correct?
Right.
Or process it. Can the processor give it back to the grower? No. there is a true handoff to the processor, and I'm saying this for everybody here, a true handoff, and then it can be sold to a dispensary, and it could be sold back to the grower for a discount potentially.
Well, that, I mean,
As
that's
a
the
patient, as a patient.
Oh, to the dispensary. From the dispensary.
From the retail, OLCC or wherever licensed retail site. Or in your case, it's a dispensary here. I'm thinking about how practically a grower is going to be vertically integrated. I think that's going to be more clear than anything else. There are going to be golden extracts, and a few will have their own grow sites, but also purchase from others, these large processors. But most growers of any size will probably have their own processor. Is that? And then can you transfer it internally for $0?
Well,
There
I mean,
doesn't
on
have
the
to be a
medical
dollar
side,
amount to track.
I mean, if a grower could give marijuana to a processor that was owned by itself and not pay any money for that, but the processed product can't go back to the grower for the grower to sell, right? I mean, you have to have a registration as a dispensary in order to sell, right? Otherwise, the grower is operating as a dispensary and doesn't have a registration.
Here's the challenge for the industry, and again, this is more of a policy question we can discuss after lunch. Medical patients, if you start talking to the doctors more and more, and as the industry evolves, patients are going to smoke marijuana very much less than they do now. They will begin to vape. All my doctors are making recommendations of vapes, capsules, or anything else. Those are all processed products. So I think we as an ACMM need to recognize that a grow not connected to a processor, I don't know how a patient growing those 16 or 12 plants or 10 plants at their home is going to be able to make a medicinal product. That's my.
Let me tell you how.
Okay.
Go ahead.
A patient can take marijuana to a processor. The processor cannot, the patient can't accept any money for that. The processor processes the product for the patient, and then the processor can get reimbursed by the patient for that. And then the patient can take that product back for their own use.
But they are not allowed to take it to a dispensary for reimbursement or.
No,
Correct.
not unless they have a processor license, right? Because the only registered processors starting in January are gonna be able to sell processed products to dispensaries.
Yes. If they were a registered reporting MMGR, that's not allowed. No.
Processed products, no. Growers can only sell usable marijuana immature plant seeds to dispensaries. You have to have a processor registration in order to provide processed products.
Edibles or.
Yeah.
I think I've got ours.
Anything else, Bob? Is that the answer?
It's well enough.
Maybe not the answer you wanted.
No, it's fine.
Yeah,
Okay.
Oh.
Keep your question, we'll get it later, I'm
Yeah.
sure.
Yeah.
Okay, so page 37 at the bottom, that's where it talks about the form prescribed by the authority as an intake form, the same thing we talked about for dispensaries. And page 38, same thing, adding harvest or process lot numbers to that form as something that needs to get recorded when product is brought in. Sub 6 is the deletion of the October 1 date because it won't be necessary once these rules go into effect. And then sub 7 is being deleted out because there's with the new testing rules, like that takes processing site. Processing site can transfer to another processing site if needed, or to a dispensary. So it's again, just making sure all the information is being recorded. Page 39. Again, it's just clarifying what information needs to be recorded there. And section 333-008-2120, there is some clarification being made for surveillance equipment and how it's to be locked up, located, and all that. And that continues at the top of page 40. There's just corrections made because we added the sections before. 2190 enforcement. There's clarification being made for follow-up action from dispensaries after inspection. In sub D, it talks about a written plan of correction that's acceptable, that the authority will notify the registrant in writing with a specific date of when they need to come into compliance. That's just to kind of clarify the process a bit more. And that's kind of what the rest of that also says. Moving on to page 41, and the last section of the rules that are being deleted out is 2130, waiver of security requirements.
How would that one be?
The waiver,
Yeah.
I believe it's being proposed to be deleted because it's turning out to be quite burdensome for the agency. And so I think, we thought the big security issue that was, that's still being allowed for is that, the physical barrier between limited access areas. And so we sort of built in a waiver to that provision. But just having a blanket, like being able to ask for a waiver for anything was sort of too much. And so I think for now, the agency would like to not permit that.
And I'm sure they can talk to you on a per basis or something.
Yeah, I mean, in particular, all the security and camera requirements and stuff like that. I mean, it's just not something where the agency, I think, is going to grant a waiver. Yeah.
And then the last rule, 333-008-9900, we are extending the dates from July 1 to January 1, 2017, where we will not impose or collect a $100 replacement card fee if the reason for the replacement card is that the patient's designating a new PRMG or a new Growsite address. And that's just to kind of help patients that are seeing their growers leave transition to OLCC to cut down on.
Is that already, excuse me, Tristan here, is that already in effect right now? Are we still going with that currently?
Yes. Yeah, we're still doing this. We're just putting it officially into rule that it's being continued.
Thank you.
Yep. So that kind of concludes, that almost
You want to do this little
concludes
bit
all
here?
What?
You want to do this little bit, operation?
That's what I'm getting to right now.
Okay.
So the reason you have two separate packets, we just went through the larger rule packet. You have a smaller rule packet that at the very top says Division 8 draft rules for emergency temporary filing. So this is going to be a temporary filing that the agency will probably do relatively soon. But these temporary rules are going to get adopted permanently into this rule packet. We just kind of wanted to have that separation so you know this is temporary, going to go into effect immediately upon filing, but it's also going to become permanent when we move forward with the rules we just reviewed. So what the agency is proposing to do with these draft rules, or temporary rules that will get filed soon, is we are going to extend the date from October 1 to January 1, 2017 for when dispensaries need to be licensed for food safety with the Department agriculture. That's the first rule change in, under operations on page 2 of your packets. Next section, transfers to registered dispensary. We are also extending the date from October 1 to January 1, 2017 for when a processor needs to be registered. But with that, starting on October 1st, if your processing site is listed on our website as having submitted a complete application, those are the only processing sites that can transfer. So patients, caregivers aren't going to be able to transfer marijuana products like edibles, concentrates, tinctures, if they're not a processor that submitted a complete application with us or registered with us.
As of what date? October 1?
I think
Yeah.
I understand what she's.
It's a transition period. We originally had October as our date. With going through applications for processors and the amount of time it takes to kind of go through those and get paperwork back from applicants, review that and have them move through the application process. We're finding that we may not have anybody registered by October 1st, but to allow products to continue entering dispensaries so that patients and caregivers can purchase. Yep, we're gonna allow anybody that's gonna be listed on our website to continue transferring. It's just.
I think this is hugely important and was a real benefit for the processor community. I thank you for doing that.
Yeah.
But
That's
that is,
huge.
as of October 1, they have to be on that list.
Yep, and if
But
somebody
they don't have to
submits
have
an
their actual
application.
license,
No, it's
which is
just-
nice,
it's
because
just
we've had a
Yeah,
lot of people
somebody
not gonna
submits an
show up.
application after October 1 and it's complete, they can still be added to that list.
Okay,
And they
sure.
can still.
So
continue
I'm on the list
Awesome.
right now. It will continue on like that until then.
Yep,
Okay.
Well,
but
Margaret, so, I mean, because I don't know when these are gonna get filed, so these are temp rules, so they're gonna get filed immediately, because we don't say October 1, so.
Okay.
So we should just think about whether or not that's gonna start October 1, and if so, we should probably say beginning October 1st.
Say
Because
what?
because they could get filed tomorrow, these could get filed tomorrow and be in effect.
Okay.
So the,
What's your point, Shannon? I'm missing it. I'm sorry.
well, I think if these rules were filed tomorrow,
Yes, ma'am.
then starting tomorrow, a sort of patient processor that was processing their own stuff that hadn't submitted a complete application wouldn't be able to transfer to dispensaries anymore. So,
We either add the October date or wait until October 1.
right,
Yeah, just put in October 1st, I think.
yeah. I mean, I think it would be good for people to have a little bit of lead time. So
Yeah.
probably filing them earlier and putting in the October date.
Yep.
Yeah.
November 29th.
Just 3 days starting.
Okay.
Okay. Awesome. So that, yeah, that's the end of the rules. You do have a statement of need and fiscal impact form for reviewing. It basically explains everything we just kind of went over in the rule packet. Some of the rules that we are filing are mandated by the legislature from bills that they passed this past session. So just be aware of that. That's mentioned in this fiscal impact statement. As far as there being any fiscal impact on these rules, that is mentioned in the statement. And I think, let's get this really quick, I think for the most part there is no financial impact to really anybody in regards to these rules. But please review this and get us comments when we reconvene after lunch. If there's anything that you see in this you have questions on, just let us know. We'll kind of start the next part of the meeting with asking if there's any questions on this impact statement.
Okay.
And other than that, we can
Have a lunch.
review.
Okay, so we're gonna,
I have one, it might be kind of off, but I'm just trying to remember exactly when, because I think it's backwards, but we can't sell hash right now, because it's considered I'm gonna say this wrong, considered the extract and not the concentrate, so as of October 1st, can we sell the extract?
I'm
I
not
think I'm
sure
saying
about
that
any of that.
backwards.
I don't understand.
For early start?
Yeah,
No, I mean, the early start rules are set.
okay, I just couldn't remember if it was in there, so.
What's the difference, just so I understand it from your perspective?
Well, technically, we can't sell hash even though it's water-based because under the way that it's.
Yeah, so to retail customers.
Well, define
Because
what
it's
you
a
consider to be
concentrate.
hash, okay? I just want to make sure.
Water hash, hash, like water hash.
Because it's a concentrate.
Like bubble?
not-
It's considered, yeah, I was saying that backwards.
Yeah, so I think you can sell.
Like ice wax and stuff like that?
Yeah.
Okay.
Because you can only sell the extract. under-
So processed, you,
Yeah. I was just trying to remember when the.
Yeah, it's extracts that can be sold to retail customers during early retail sales,
And
and
not
concentrates,
concentrates.
and not, yeah.
Which seems,
What we were mandating.
let's sell something that's chemical and not. I know it's not.
Okay, so we're gonna break for lunch. We have 1 hour to 11:51. We'll be back at 12:51.
Okay.
Order. We're gonna have Andre, provide a report for Senate Bill 1598. Before he comes back, I just wanted to touch base with all the members again and see if there were any other comments in regards to the rules that we just discussed.
I have some comments or questions. Margaret, I think you may be able to answer them. And if you can't, then we can wait, or you can maybe call Shannon back. Okay, we were at lunch, and there's still some confusion about timing and dates. So I think it would be good for not only all of us, but also for the people who came today to understand more fully. There was...
Do we have a quorum?
Todd and Tristan, are you both on the phone?
Tristan is here. Todd is here.
So you got two there.
6, 7, 8.
And we don't need a quorum for the rules, just.
Right.
Okay, so... Well, I don't think we're taking any action right now, Anthony. We're just answering questions.
Yeah. And it's just recommendations for the rules, since there's no vote on the rules, there's no quorum needed for the rules.
But
That's not true.
That's what
That's
we were
not what
told.
the administrative rules say. They are quorum required.
But we're not voting on anything, so no quorum's required.
well, we have a quorum now with 8, right?
Yes.
Yeah.
So we have 1, 2, 3, 4, 5, 6, 7. Okay.
And you have a question, you can ask your question
Right.
too.
Okay. So we have some dates out there. We had a June 30th date. We had an October 1 date. We have a November 29th date. And we have a 1/1 or 12/31, 16/11/2017 date. So if we could discuss those dates pretty much about what's really important. And let me see if I can, see if I say it right. We have pushed most of the October 1 compliance for ODA, for the lab, and some big issues to essentially 1/1.
No.
11/29?
No.
Okay. All right, go ahead.
Okay, so let's start with October 1st.
Okay.
October 1st, testing, labeling, packaging, all has to be in compliance with the new rules that went into effect June 30th.
That's correct.
Okay. The rules that we just reviewed, those are the rules that we are planning to have take effect November 29th. Okay?
They do take effect November 29th.
That's our plan. To have them go into effect November 29th.
So what happens for the lab that's registered right now with you all and we haven't done the full inspection? Are you going to complete that full inspection by 11/29? If they're going to stay or?
A lab?
Yeah, processor, sorry, processor.
Processor.
Sorry,
okay.
processor. I always call the lab processor. My fault.
Okay. Processors, that is where that emergency temporary rule we discussed comes into play.
Correct.
But it also, so it's a temporary rule, but we're gonna make it permanent on November 29th. So as soon as we have a final, well, I guess this is probably gonna, as soon as we have a final draft of the emergency temporary rule. We're gonna file it, and the date of filing is when that rule is gonna be effective, and that rule is gonna state that you have to be a registered processor or have submitted a complete application for a processor in order to transfer products between October 1 and December 31st, is essentially when that's gonna state.
Okay.
And then come January 1st is when you have to be registered in order to continue transferring products to dispensaries.
And what's important about the 11/29 date right now? What Cinderella type activity do we have around that?
Why did we choose November 29th? Or?
And what's specifically important about November 29th?
So in the rule package that we reviewed, the first package, that included early retail sales.
Right.
Those rules are currently temporary because we had to make changes because of legislation and allowing the expanded products.
Right.
So because it's a temporary rule, that rule is set to expire November 28th.
I
If
see.
we want to continue doing early retail sales, we have to adopt these rules November 29th.
Because temporary rules are only in effect for 180 days.
I see. Okay.
And then the agency has to either get rid of them or make them permanent. So November 29th is the day to make those.
So I hope you understand that I'm asking all these questions for
Yep.
a lot.
Yep,
We're out
right.
here, as well as a little clarification for
That was good to
the
clarify.
slow one here.
So
there's a lot of dates.
There's a lot of
there is,
dates, yeah.
and what's significant is that previously with the June 28th rules, we said processors have to be registered by October 1st. It's just not going to be possible to register all these processors on the retail and the medical side, because I mean OLCC, to my knowledge, hasn't even issued any processor licenses yet. Processor license, in addition to 2 laboratories. So it just wasn't going to be possible. So today is August 31st. We essentially have a month. It just wasn't going to be possible. So we wanted to allow those processors to still stay in business, transition into the regulations, but then, still give them some time to get inspected, come into compliance without shutting everything down October 1st.
Do you guys believe that those applications that are pending for processors will in fact have been, you guys will be able to get to that process by January 1?
When did you apply?
To actually register?
That will depend on a lot on the processors, whether they want to go over to OLCC in that time period. Because, January 1st comes along,
You're not on the website.
and we no longer have early retail sales
Now you
through
are.
medical dispensaries. So those processors are going to be processing product that can only be sold to patients through the current dispensary system. So I would hope for their business interests that they've applied to OLCC by then. And then once they've applied to OLCC, they drop off our list. Like, we don't need to register them because they can't be dual registered. They can't be registered both under OLCC.
Yeah, obviously, that's what I'm gonna let you guys know in an email. I'll probably
Yeah.
switch all my functions to OLCC, and you won't have to come register me or inspect me, really.
And then also, it's the same for dispensaries. So we'll come out and we'll give you your readiness letter and say within 60 days, you have to essentially have everything in and be ready. So that will depend on the individual business, whether they're ready for us or not. It just buys everybody 3 months.
Yeah. And I don't think anybody in this business, in all candor, is trying. I think they view this as a privilege.
Yeah.
And I don't think anybody's trying to violate any laws. But I will tell you that the regulations and the laws have become significantly, if not exponentially, more complicated for all of us.
Yep.
And it's just hard.
Humans included.
Yep, I agree. It's a lot in a short period of time.
And I think the other thing is, and I don't know, Margaret, if this is open forum or what we need to do, and you need to guide me, but I think one of the discussions that kept a lot of the individuals right at this table, we have an MS society, we have a retired oncology nurse, we have some people who are patient advocates but also dispensary owners, and we have Tristan and others who are very much advocates, and certainly in the audience I know of at least 2 or 3 who are advocates.
Todd, science.
And Todd as well. I think we really need to take a sweeping view of what the new legislation has actually done to the medical cannabis patient and their welfare, and whether we can do anything either through new legislation, through new regulation, or something to protect them from what is perceived to be a much harder opportunity now. We're clearly in the industry, we're not sure where these patients are going to go to now to get their medicine. And you had stepped out and we talked about processing, and it's going to be really a challenge for medical patients to get processed product. Maybe. Maybe. I don't know how to do it, but I will say that medicinally, all the physicians now are looking at smoking as not being the proper mode, and the industry is really evolving. So you've got the PAX thing that's sort of a vapor. You put a little flower in the bottom of it, the PAX sort of thing. That's okay, but honestly, capsules and sublingual stuff are really the way where it's going, and those can't be easily made by a patient, and we don't want them having open source systems and blowing up kitchens and doing stuff that has been done in the past. So I don't know what to say to do. I think we have to look very hard at what hasn't, and it's, as we said on the advisory, what was the group that was, when I first met you?
The Rules Advisory.
The Rules Advisory. When we served on that, we all said, guys in the audience, because we had large audiences, we said, this is not our doing. We are just responding to what the legislature wrote. And indeed, that is what we have done. And so we at the ACMM, I think you have some really, the people I've met are really interested in trying to help patient rights here. So whatever we can do, I would like to see this committee very much focused on that. Let's help patients get their cards, do whatever we can.
I guess
And
my
their
biggest
product.
concern too is with all this crossing of everything, it leaves patients nowhere to go. Because I don't know one dispensary owner, and I know almost all of them in the state that is going to stay medical, because you can't make it if you don't have RAC. But where are the patients going to go? If they're not able to get the medicine that their medical grower was doing for them, and now they're our medical grower and they can't take it to a shop, whether it's medical or RAC. And I feel like we're losing a big loophole right there, and we're going to authorize medical growers to stay medical, but then what do they do with their excess if they don't have a shop to take it to?
So
have you guys thought about that? If you have
and those are considerations that have been addressed by the legislature already. And I think a lot of it is educating the public and the patients that they do have alternatives and pathways to access medicine. So just because you are a medical patient, if you are growing under the OLCC system, you can still grow for your medical patients under an agreement and provide them with free, discounted, at cost, usable marijuana from that grow site that is an OLCC grow site. So that's one pathway.
And we cleared that up until you were gone. That was very helpful.
Another avenue for, as far as processed products, the patient can always take a supply of product to a processor, have it processed at cost by the processor, or the processor could do it for free if that's what their decision is, but they're not to retain a profit for it. And they can process that product in whatever form the patient needs it, or they're capable of processing it, and return it back to the patient. So
it has to be a medically licensed processor.
Yes. So that's something that OLCC probably needs to consider.
As a processor, that's not feasible to do such a small run. I mean, that's
Right.
going to be the hard part.
Right. So that I would say is something
We could all pool together and have a medical processor.
The downside is for extract, it's a felony if you don't have, if it's in your possession and hasn't been purchased from a dispensary. That has to be addressed in that.
The extracts.
That exchange.
Is that, Anthony, that's,
Yeah.
I mean, all these rules are You know that.
Well, it's a law. It's not
It's a law.
I know
Felony
the law,
possession.
yes, I know that.
So,
But we just spoke about the fact that most of the processors that have applications with OHA that have an MMPS number are more than likely going to be converting to OLCC.
Right.
So then,
And they can
is
still,
the patient able to go to
yes,
an OLCC process?
absolutely.
Okay, great.
So, well, they can go, no, they have to go through the dispensary. So the OLCC processor can still process medical grade products at medical concentration levels and sell that at medical limits to a patient. So the patient still will have access to get into a retail OLCC dispensary and buy tax-free products. So it's like any other pharmacy, right? So you can go into a pharmacy and buy your over-the-counter supplements or Advil, and it's, I don't know what it is, in Oregon there's no sales tax anyway, but it'd be tax-free. So they have a retail avenue. They also have a personal avenue where they can send it to a processor, a medical processor, although that's limited. So that's more of OLCC's purview. And of course, they can still produce medical marijuana by themselves or have someone else grow it and produce it for them. And there's always, you know, besides extracts, which is a dangerous process, they can always have homemade concentrates, edibles that their caregiver
Then I
can
just feel
do.
like we're flooding the black market again, and we're gonna have more cases of people overdosing or having that issue of overdosing.
All right, there are two basic, this may not be our purview today, but it's certainly something that we, as the ACMM, you as the OHA, we as a state have to look at. There are a ton of medical growers who are gonna go off the grid again. And they're gonna grow, and they're gonna grow illegally, and because they have no way to become licensed under OLCC, either because of zoning or other things. It's just an issue. It's not really our purview to discuss illegal activities. I understand that. That's a reality. So, what I'm concerned about is redefining our mission here. Because if we're not going to be dealing much with dispensaries, we're not going to be dealing much with processors, and we're not going to be dealing much with growers, we need to really look at what our mission is as the Advisory Committee for Medical Marijuana, advising the agency.
So Bob, your mission as an advisory committee is in statute. So that's all dictated by what the statute says as far as the function of the ACMM. And it's to
Okay.
advise the AC, to advise OHA on the administration and rulemaking regarding medical marijuana.
And the annual license fee structure.
Yeah.
So it's pretty targeted?
Yeah.
Yeah, it's narrow, but it's broad.
So what I'm saying,
That was awesome.
okay, well,
I am a professional bureaucrat.
I get that. No, it's all good. I'm just saying that what our mission though is, within that, there's things that we can do though. I mean,
I wanted to go into the concern of access, as Allegra mentioned earlier, flower, usable marijuana, by the medical growers. Right now, we have created a system where they can insert it into a legal regulated market as best we can right now. So.
To a retail market.
Well,
Or both.
no, it's both right now, right. And as things transition, we don't know yet how many dispensaries will be converted to OLCC. Majority probably,
Oh,
right?
yeah.
Okay. So what will happen to the excess now?
That's a good question.
It's kind of opening up that we're going backwards into a black market in that aspect potentially.
Especially when we got like 38,000.
it is conjecture though.
Yeah.
That is conjecture.
Look, you know what, your decision to enter into a black market and do things illegally, I mean, you have to, okay, am I gonna take if I were a business owner and I owned a dispensary, I have been granted a privilege by the state of Oregon to conduct a business that the federal government has said is absolutely illegal. And they doubled down on that position 2 weeks ago.
Right.
So they're not budging until Congress acts. So essentially, this state of Oregon has said, federal government, we understand that you think it's illegal, but the citizens of Oregon have decided that there is a benefit to this substance. Medicine. And we're gonna allow our citizens to have regulated access to it. And the federal government says, as long as you're regulating it and everybody's playing by state rules, we're gonna stay out of your business. Okay, that's the deal between the federal government and the state of Oregon.
Right.
So me as a business owner in the state of Oregon, I'm gonna make damn sure, and I'm probably on the public record, so I apologize for the cursing, but I'm gonna make sure that I am compliant with state law.
Oh, yeah.
Because I don't want the DEA coming into my backyard telling me I'm not running my business correctly and then I'm gonna be facing prison time.
And I guess I mean more black market as patients are gonna be having to go there.
So,
Same goes for patients.
and the same goes for
Yeah.
patients,
I
because
mean, they're not gonna go over just businesses, they're
They've
gonna
been
go
doing,
after.
they've been doing it.
medical
forever.
marijuana is still illegal federally, even though we're calling it medical marijuana, it's still federally illegal. So,
Except for 2 patients.
sure, you get your NIDA exception or whatever. But generally, you have to make a decision. It's like, okay, the state of Oregon has said, here's the playing field and here are the rules. You want to stay out of trouble and you don't want to take any risk, play by the rules. You start going outside those rules, I mean,
That's
wait,
your
OHA is
fault.
not going to help you.
No.
OLCC is not going to help you. Law enforcement is, those are risks that people need to, that are assuming. And as far as the growers down in Southern Oregon that, you know, they had a good thing going on with the medical program, Measure 91 came along and said, nope, we're going to have a robust regulatory system. We're going to control this as a vice. We're also going to control it as a medicine too. We have an avenue now to put product into a retail market. If you want to be a licensed business, then you do that. Or if you want to stay in the medical program and be true to the intent of you want to provide this out of the goodness of your heart and compassionately to medical patients, we have an avenue for that. If you want to take that third route and go illegal into the black market, okay,
I
that's
guess
your
it just makes me
decision.
sad that we're pushing it, or that we're
I mean, it's like that for any other substance, right? So if you have a still in the woods and you're making liquor, you know you're bootlegging liquor, right?
Yeah.
And you're taking all the risks associated with bootlegging liquor. Or you can go get a license from OLCC and brew your beer or your liquor according to their laws and rules. It's doing the same thing for marijuana. And you know what? Is the state of Oregon going to really care about a medical patient growing 6 plants and giving out an ounce or 2 to their friends? No. Just like the home, no one cares about the home brewer making a barrel or a batch of beer and giving it to the friends, as long as you're not reselling it and putting it on the market. So, I mean, the practical effect, are people gonna make choices to go into the black market because they don't wanna play in a regulated field? Probably, but that probably happened at the end of Prohibition in the 1930s. It's gonna happen with any regulated market, so, I mean,
This was just, these are.
And I'm not trying to advocate
No,
one
it's
way,
just
I'm saying this is
editorial.
the perspective
No,
that I have.
it's just a reality that we all are, there's a lot being said more for the audience and for the record than it is for us who are in this business
Wait for comments after.
and we're gonna have that. I would like to discuss what your vision is for this committee, along with Margaret's, what you'd like to see this committee evolve into.
Well, it's limited to whatever the statute says. So I value your guys' advice on our rulemaking. You know, I don't think, we have an ACMM and you guys' legislative directive is to advise us on the administrative aspects of the program. So I felt like we don't have to have additional RACs when we have a RAC here.
Yeah.
And we have members that are, by statute, have to be involved as advocates or participants in medical marijuana. And we have that, so that's what this utilization of this committee is for.
What about doing like medical research or anything else under the purview of the OHA or anything like that?
That stuff is more directed by the policymakers, which is the legislature.
And there are some committees, but
And there are some committees, so we had the SB 844 committee last year that wrote a report to the legislature saying, well, if we want to do research on medical marijuana or marijuana in general in the state of Oregon, here's this committee's report and this is what we think. And the legislature needs to take that report, read it, and then make policy based on the information that they're provided. And then once they make that policy, then they tell the agencies to implement that policy, and then that's where this committee comes into effect, is how best do we implement that policy that's been decided on. So that's the function.
And I agree with your black market statement. I do believe it's choices. I guess it just scares me to see those medical growers who are willing to stay medical and not be able to make their profit and go to the retail shops.
It's
That's, you know,
right,
but I agree with you 100%.
It's
That's
a
your choice
byproduct
view.
of legalization.
Yeah.
I mean, you know, legalization, Measure 91, if you read it, right there, it said robust regulatory system.
Oh,
And
yeah,
that's what we got.
Touch
the medical marijuana program.
You know, and that's up to, and that's not that literal. I mean, that's up to interpretation by judges and lawyers.
True.
And essentially, the medical marijuana is the same. We still have patients, they still have cards, and they still have access to marijuana that other people don't have access to. So has it changed that much in the?
But it's changed.
Yes, of course, because we have recreational coming into play now, which changes the whole thing. So I'm going to give you my personal 2 cents without being too opinionated. So Measure 91 legalized the recreational use of marijuana in the state of Oregon. And that, by effect, changes the way that the medical system and the medical regulations were being administered since 1998. Because, tongue-in-cheek, wink, wink, nudge, nudge,
Yeah.
not everybody that was involved in the medical program was doing it for legitimate purposes. I don't have numbers, and I'm not going to say a percentage, I'm not going to say most, but we all know that not everybody was doing it out of the goodness of their hearts and for compassion for sick people.
Right.
But that was the avenue and the cover and the beard for people to produce marijuana on a recreational and a for-profit basis. So now we have Measure 91 that says, all right, let's have this all out in the open and let's regulate it appropriately. By doing that, you've now significantly changed the way that people are producing marijuana under a regulatory system. So now we have a recreational system where companies can make a profit, and we still have a medical system. My opinion is, and my administration of this section is if we're going to call this medical marijuana, let's stop winking about it, let's stop putting the tongue in the cheek about it, and let's make it legitimately medical. And what that means is that we have to now regulate a medicine in a way that generally the federal government regulates it. The FDA approves drugs for safety and efficacy. Well, the states just don't have enough money and resources to do that effectively like the federal government is. But this structure here that we have with all these bills and all these rules is essentially taking that system and regulating the safety and efficacy of medical marijuana for medical purposes. And if you don't want to play in this system and you don't have the integrity to say that I'm doing this for compassionate use and for medical use, then go to OLCC and make your buck there. And that's it. I mean, it's that simple. So now we have rules for labeling because we want to know what people are putting into their bodies. And you know what? You might grow, and I'm saying you as in the general term, you might grow organic marijuana or cannabis, and you are confident in what you are feeding your plants and giving to other people and patients. But not everybody is honest as you are. So we want to know what pesticides are in these products. What solvents were used to process the products? Is there truth in advertising? Is it as potent as you say it is? You know, so those are all functions of a safe medicine. That's kind of where we are, and it's kind of a painful transition process. And I think that a lot of people are going to be confused. I know that we get calls every single day. We get hundreds of calls a day. I get lots of emails a day, and patients are confused. Patients don't know where to go. I mean, is this the third or fourth permanent rulemaking that we've done in 9 months? I mean, this is crazy. I mean, for me, I think it's crazy that we have to go into rulemaking every 3 months, and when we have, I don't know, 100 pages of regulations.
And the work that still has to be done.
And and then managing a program and ensuring patients get their cards. you know, so this is, it's not easy. It's not easy for patients. It's not easy for the agency. But I think that the direction that we're going is the right direction. Now, are there bumps in the road? Yeah. Are there problems that can be corrected? Are there things that can be done better? Yes, yes, and yes.
Every road's got a pothole.
But, you know, October 15th, October 1st, 2015, that's the first day that this has basically been a legal substance in the state of Oregon for everybody. And now we're at September 1st, 2016. So in 11 months, we've come this far. And we've dealt with this much stuff, change. So, you know, I know people are going to be impatient, and that's...
I don't think impatient.
Yeah, it's understandable.
It's not impatience. It's not to interrupt. It's just, you and I have had this. It's hard for the agency. It's hard for the industry. And it's hard for the community.
I mean, yeah.
It's just hard.
Changes are. That being said, can we change our mission?
So what we can do, and what I brought up at the last meeting, is that the bylaws have not been revised since like 2011.
Yeah.
And I looked through my files and I saw some attempts at revising those bylaws and the mission statement. So as long as we stick to the statutory intent and language of the function of this committee, we can change those bylaws and kind of, you can add things that you can add that wouldn't be outside of the statute. So, you know, I'll talk
an example.
Like, yeah, so I think this is a version from like 2009. I think there was an attempt in 2011 to edit them, and then it just fell through. So 2009 stayed there. So, you know, I can talk to Cheryl. You guys do we have a quorum today?
Yes.
We can have a vote to put this on the agenda for the next meeting and discuss how we want to edit and amend bylaws within the framework that we have.
That would be great.
Can I get a motion?
I make a motion, or Allegra makes a motion, I second.
Because the mission is
Discussion?
no longer
State the motion.
really relevant.
Restate the motion.
Stated, made a motion.
I make a motion to add the bylaws to the next agenda in order to review and possibly make some changes.
I second that motion.
Discussion?
I'm excited.
All in favor?
Aye. Tristan and
Aye.
Todd, good.
Now, I just want to give the caveat is that Shannon O'Fallon and I and Margaret are going to play the bad guy and keep you guys within the lines that you have to stay in.
That's fine.
Motion passed.
Change it in session.
And of course, if the legislature changes it in statute, then it's a completely different ballgame.
Okay. Would we like to move on to Senate Bill 1598? And thank you so much, Andre.
So I'm sorry, that was my soapbox.
2 cents soapbox.
I've given that speech
Is that
multiple
Ty and
times.
Downing?
No, it's good, Andre, but that's what we wanted.
I mean, it's just,
That was great.
it's my perspective on where I think they're going
Well, and you're knee deep in it all, so it's good to hear from your perspective.
sometimes. Sometimes I can't see through the trees. Okay, so I asked Cheryl that this be put on the agenda. SB 1598, Section 31, asks the Oregon Health Authority to write a report to the legislature on, so here's the language, and I'll read the language out loud. The Oregon Health Authority shall study methods by which medical marijuana dispensaries may dispense usable marijuana, immature marijuana plants, seeds, medical cannabinoid products, cannabinoid concentrates, cannabinoid extracts, remotely in areas of the state where individuals who hold a registered identification card issued under the statute of the authority of the agency do not have access to a medical marijuana dispensary. So this is for patients that are an opt-out. So the counties opt out of everything, recreational and medical. So on or before January 1st, 2017, the Oregon Health Authority shall report the authority's findings under subsection 1 of this section to the interim legislative committees related to health and any interim legislative committee specifically related to the regulation of medical marijuana or marijuana-derived medical products. So, you know, looking around the agency, we don't have much expertise in drafting this report. So my idea is to give the ACMM this assignment, of course with our help and support in drafting it, in coming up with this report and the advice to the legislature on what are some methods that these dispensaries can dispense products to patients that don't have access to it because of their geography.
And this would be through medical dispensaries, not through
Yeah.
OLCC?
So it says by which medical marijuana dispensaries may dispense.
There is a delivery category in the recreational, but it's not our purview here.
Correct. I was just trying to find that definition there.
So I think I think I would like you guys to draft it and come up with the ideas. If you want to form a work group, like a small work group to do that, that's fine. I think our role here would be, if you guys say, well, we can have a delivery bus, then I would have to go to Shannon and I'd say, what in Oregon statute prevents us from having a delivery bus? You know, so we can kind of check off the legal aspects of the ideas.
I think it would be good to have a conference call with Shannon in the next couple weeks to discuss the legal, I mean, I think that.
The limitations.
Limitations, yeah, I do. I think the fact that, does the law say that you are only allowed to sell within the four walls of a dispensary? And if the law says that, how do you get it to a remote area if they didn't prepay it?
My other concern
Well, you know, this is a report, this is not
Yeah.
policy generation, so you can say, hey, legislature, we think a good idea is to have a delivery system, but the legal limitations in that is that you guys made it illegal to do that.
Fair.
If you want a delivery system, you're gonna have to change these laws. So that you can include stuff like that, that's the language that you would want. in your
Okay.
report.
Then that
And the
makes
opt-in
sense.
and opt-out abilities of the cities and counties, and how will that offend them? Can we still offer that service in those areas that say we don't want to participate?
You really don't want to open that Pandora's box.
I know I don't, but it's what's coming to mind. So, does the ACMM accept this assignment?
I'd like to write it.
No?
I'd love to work on it.
Okay.
I think you need a vote.
But I
Okay.
guarantee you Eastern Oregon and some other opt-out counties do not want this, and they will be pushing Senator Ferrioli very hard.
Can I get a motion?
I make a motion that we work with the agency to develop a report for the legislature regarding the dispensing of cannabinoid, cannabis, and other related products to remote areas of the state of Oregon.
I'll second.
More specifically, opt-out counties.
And Melanie,
Second that.
Second it. Tristan seconds.
Second.
Discussion?
And I think, so this is a little bit of discussion if I may.
Yeah.
I think where a good starting point is, I think the authority can provide this committee with some basic background statistics on which counties and how many patients in each county would fall into this category. So I
Okay.
think that's a starting point as far as defining the scope of the problem.
Okay.
Are we, part of it is right here though, right?
Yep, it's in your statistical snapshot. So we would just have to go and check and double check which counties have opted out, which is on our website, add it up and send you guys those numbers.
Okay, true Oregonians, Ontario is in what county?
Malheur.
Malheur. So there are 470,
I deal with oodles from over there in the John Day area, I'll tell you that. That's a big issue over there.
and that's Grant County. No, that's not Grant County.
No.
That's,
Yeah.
John Day is what county?
I believe it's Grant County.
It is Grant. Isn't it?
So the way I kind of see this report is that you guys can make it whatever you want to make it as far as the methods that you're suggesting, but that we just at least address the limitations of those methods. So if it's illegal, we can say it's illegal. If you want to make it to work this way, then you would have to change the law.
Can we make an editorial comment that the number of medical marijuana dispensaries may be decreasing, and that this should also be looked upon by other agencies?
Yeah, I mean, I think you can provide information like we project we'll have this many dispensaries left, medical dispensaries only.
Yeah. So this is really more a concern perhaps of the OLCC business market.
Like those citizens that live in counties and cities that have opted out of medical marijuana.
Right. Or all marijuana.
Well, I know, you know, by Oregon law, even if you live in an opt-out county, as a patient, you cannot be prevented from growing your own Six plants.
Further discussion?
This is Todd here. I just want to say that this kind of project is the kind of project that is the crux of what I think the ACMM should be doing. And the kind of project that I've been wanting ACMM to be asked to do for years. And if you know, and if we can have the support behind this and the response, then I'll just be tickled. So I thank you, Andre, for putting this on our plate, giving us this opportunity, and I fully support it.
Thanks, Todd. I would echo that. Okay, are we ready to vote? All in favor?
Aye.
Aye. Opposed? Motion passes.
That was an aye for me.
Oh, no.
Yeah, I got a late aye in there too.
We heard you.
Thank you.
I think it was unanimous.
That was unanimous.
This has to be presented to the interim committees?
Yeah, so it's
Does that have
whatever.
to be done during a legislative day, or it can be sent in for their?
We'll handle that. We just have to do it on or before January 1st, and I just send it to our legislative folks, and they give it to the appropriate committee that wants it.
Because nobody adopted a deadline for completion of the report in the motion.
It's in statute. Oh, well, I mean, as far as,
When they should have their report done.
I mean, it'd probably take me a day or two to edit it.
Well, I think
You can get it to me December 29th.
No, let's try to get this done by October 15th.
Okay.
Or at least have a draft by October 15th.
Yeah, October 15th should be fair. That's 45 days.
And then we have another meeting probably sometime in December.
Yeah.
I hope so.
Yeah, we have to have 4. This is our 3rd.
Yeah. Okay.
I will say for the record also, you weren't here. 2 people in the audience had to leave. One was a veteran. Andre, he wanted me to give you specific thank yous for getting some things through and passed and speeded up for veterans. He wanted you to know that.
I wish I could take that credit, but that's, his legislature did that. But I'll take the credit, I guess.
You're welcome.
It was Anthony that did a lot of work, actually.
Yeah.
Anthony Taylor did a lot of that.
Oh, okay. Well, there was a couple here who was,
Well, I agree with it.
okay, fair enough.
Okay, are we ready for public comment? Was there anything else that the members wanted to discuss? Andre, anything else?
Oh, real quick.
Yeah.
On the website training that you guys are coming up with, the new website regarding the application.
Yes.
When you guys do get that, I would love to be able to do that protocol and be able to actually
Okay.
look at it, and then that way we can get a little bit of outreach done.
So we'll probably be making those announcements like in December, because the software folks say they will be done in December. And then we'll start internal testing, and then we'll probably start beta testing, and then launching it in January. So around December, I'll start notifying you guys.
Okay, I'm gonna call Ben McInnes.
Okay. Well, first, just thank all you guys so much. Every time I come here, I'm just so impressed by the audience, and then you guys, just how much time and dedication you give, and how sometimes it doesn't feel like there's forward momentum, but in the last, like you were saying, 9 months, there's momentum already. So thank you guys so much. And I wanted to just bring up a couple things. One, if you guys would be open to considering as a group, when you look at some of those changes to your to your bylaws, I would strongly recommend.
Can you get a little closer to the microphone?
Oh, yeah, sorry. With the changes I've recommended to the bylaws, when you guys take that up, my strong request would be looking to talking to them directly about making statutory changes to the bylaws and getting support from the OMP to do that, not just adhering to the bylaws that are already in place. I think one of the things we got a lot of complaints about is the toothlessness of the bylaws and the ability to take any action, as well as just exercising the rights we have currently of budgetary ones, which we still haven't had a lot of involvement in. And so I guess my looking at to it was really, if you made the sole focus of it, the majority of the focus, statutory changes to the bylaws with Shannon O'Fallon and with approval and OMMP backing, taken it to the legislator, that would actually change. After my 5 years of being on this, I've noticed that I would say it's a requirement that you make statutory changes to the bylaws. So that's the first request. Second request is on that commercial and industrial. I just wanted to double down on that and say that for whoever's listening, that with these temporary rules going permanent, I just cannot express strongly enough how I feel that when you say specifically that having separate accesses and separate insurance points, I just keep thinking of item and item and item being in real estate, where it will just shut down a lot of businesses and it'll make it very difficult on top of the almost impossible mission of finding a dispensary location now.
Right.
Let alone if you're an existing that is now not able to comport with these rules. On top of already most people jumping ship from the dispensary and the medical side, I just see that it's really important to leave as much open as possible, specifically industrial recreation. I would also say agriculture, because I thought there could be, if you have a window, you could have a tourism aspect to your agricultural grow there, along with even with just a demonstrating piece. But you wouldn't be able to have any of those once again under those rules. So I just say be very careful with anything to do with leaving those as much as possible, everything but the residential out of it, the co-housing. And then lastly, I just wanted to say that I think that everything's moving really fast in the rules and laws, and I think that a coaching recommendation too is being open to meetings, special meetings. The approval now for special meetings is there for us. Yeah. And so for some of these, when we're looking at all these intense laws in a very short period of time, having a special meeting a week after this to go over that, as opposed to at lunch over an hour, I would strongly recommend as something of this nature and caliber that's so vastly important. I get that right now that's not as important because we don't have to do a lot, but I think we have the support now. You know what I mean? And with that support, let's rally that really into making it so the ACMM really does have power, and the ability to make a difference. So thank you guys so much for all that.
Thanks, Ben. Art, you were signed here. Was that just, did you want to get up and speak?
No, I'm going to review probably afterwards, so I want to take the time to kind of lock up with the appreciate education.
Okay. Mike Rockland?
Rockland. I'll come closer to you so you can hear me that's the microphone I assume. Okay, hi.
Hi.
Yeah, I appreciate the opportunity to talk and hear, and I think what I've seen, I've been in a number of these meetings, that it feels like it's moving forward. So thank you, Andre, for your leadership and new faces, help with different eyes and ears. A couple comments. One is, I like that idea that Andre brought up about posting some other meetings, on a webpage. And for this meeting, if you post minutes, I haven't seen minutes in the past. I don't know what the reason is, but if there's minutes to be done, if they could be posted.
Yeah. We've done through minutes. Yeah.
December is the last minutes
Right,
I saw
I noticed that as well, Shirley.
on the website.
And we've sent out the minutes for review by the chair. She just has some personal things she's dealing with, so we'll get them.
Oh, okay. So
for the June meeting and for the March meeting.
Okay. So that's,
we're a little behind.
I hear you. All right. Thank you. The other thing is, I'm very interested in nonprofits. I'm a medical professional licensed in the state of Washington and state of Oregon.
Okay.
And what I'm interested in with the nonprofit rules that I saw, and there's a little bit more fleshing out of the whole idea, specifically the logistics of doing that, because in terms of the income, I would suggest maybe at the front, and maybe we need to take a look at the statute per se, but right up front in the first line, I think it was page 25, talking about 1250 now, talks about income as a criteria, and then it goes into talk, it's almost duplicative. So maybe think about changing that first line, eliminating that, because it's already in as a criteria if the nonprofit dispensary chooses that. So it's, in one way it's done it, and another way I don't think it should be the sole criteria. That was my put on that. And then the third thing I would want to echo what Bob and other people said about the concern about medical patients not being able to access because it's not feasible for a lot of disabled people to grow their own. And so they've depended upon this relationship over the years. Cultivators have learned with the patients what to do. And so that's a really important criteria. You know, in the future, as things change, we may have a different way to do it. But this whole transition period, I don't have the exact idea in mind yet, but there are some doctors interested in more integrated clinics. And if we do that, you know, that nonprofit, that might be the way to help patients. Because right now, the whole medical function as licensed healthcare professionals in the state, pretty much the nation, are somewhat prohibited, somewhat stigmatized. There's still a huge choose one or the other kind of thing, like with opioids.
Yeah.
Cannabis. So that's a whole thing wrapped up in education. That's what I do. That's clinical, professional education. And if you educate the providers as well as the patients educating the providers, then it will happen. Right now, the providers are kind of out in never land.
Yeah.
So that's an issue, and it's really hard to break through that. Understanding, of course, the federal funding and where stuff goes. But I think there's things we can do in the state that might help that. And this is one good start, the dispensary model maybe. So if you would consider that as the committee, I think that'd be appropriate.
So to educate physicians, they do not even want to be known about it a lot because they're so scared of the federal funding.
Yeah, yep.
Yeah.
So thanks.
Thank you. Jay Knox? DJ Knox? That must be the couple.
Oh, yeah.
That might have been the couple.
Anthony Taylor? Who's this guy?
Hey, who's this guy?
Hey, Tony.
Well, first of all, I'd just like to take a minute and let everyone know that Cheryl did lose her dad yesterday morning. So it's anybody that has a contact with her, send her a note, you know, condolences. On page 14, I think it is, where they talk about veterans not needing an APS because if they're given 100% disability and all that sort of thing. I think that should apply to anybody with a condition that they're going to die from. MS patients, you know, autism people, all that sort of stuff. That should be expanded. And having done a lot of work in these languages to help veterans, I think we should extend this out a little bit further.
That would be a lobbying effort on your behalf,
Yep.
the legislature. And I'm aware there are a couple states that extend that. The patient's terminal.
I think we need to make a very clear distinction in rule and law between the difference between serving size and dosage. Medical people talk about dosage. You don't buy a bottle of NyQuil and it says recommended serving size 2 tablespoons. It says recommended dosage. And I think that's something to keep in mind because one of the things I've noticed about the medical program over the last couple of years is that it's gotten this commercial tinge to it. And that's not what this program is about at all. And the people that were growing for lots and lots and lots of patients that were stacking people up so that they could produce more and more marijuana to make more and more money off of are kind of out of the picture now. And since 87% of all the medicine grown in the state is done at gardens with 12 plants or less, I think we need to take these issues into account and make sure that there's a clear, bright line between the desires of the recreational market and the needs of the medical market. And one other thing about the personal agreements, these things are kind of tricky, and there's no, I mean, there's some stuff that has to be included in a personal agreement in the rules, but if you're transitioning from OHA into OLCC, the OLCC is requiring that you have you present these personal agreements to them for review, when in fact they're non-existent. Nobody has entered into a written personal agreement with their patients. Nobody. And hand in hand with that personal agreement, we also need to develop some sort of grievance process so that situations that arise can be adjudicated. So, you know, when a patient's getting nothing but swag from his grower, and his grower's telling him, well, anything more than 2 ounces a month you got to pay me for, those sorts of situations can result in bad blood between the patient and the provider, and those issues need to be able to be resolved. The other thing is that I lost my train of thought. So those are kind of the main points that I wanted to make. I really appreciate Andre's leadership for this particular department that he's taken on the responsibilities for. I think if anybody in this state can be pointed to as a champion for patients' rights, I think Andre is the person that we should look to, because he has a grasp of the needs of patients and how the process works and what you have to do to make it better for everybody. And with his guidance and the help of everybody on this committee, I think that the patients are going to come out on the other side of this much more protected and have good access to low-cost medicines.
Would you put that down in writing?
I absolutely. Absolutely.
It's
So, all right, thank you very much.
Thanks.
And we need to thank you too, because we know you've done a lot of work out there.
Yes.
You're welcome.
And Andre too, we have to thank you,
Yeah.
because I have only been on the committee a year now, but I've also been in the audience for the last 4 years, and so I've seen a huge change.
Well, I got a really good staff that's really dedicated and works really hard.
That's good. The communication has been great.
I appreciate it, thanks.
Lori Duckworth?
I'll come closer even though I know I got a loud voice. Hey Tristan and Todd. Andre.
Thank you.
Thank you so much. We've just seen the program change immensely since you took over, and we really appreciate all your hard work and the staff. And the committee, it has really taken shape since our others have left us. And I appreciate all your hard work. And we miss Cheryl today. So I would really appreciate if you reached out to my friend. We have some concerns coming out of Southern Oregon, as we've talked about today. House Bill 3460 was written with the intent that the medical marijuana growers would have somewhere to take their overage. Now that's not even a possibility without them buying a special license through OLCC. Patients in
Can you explain that?
Yeah. For example, the average farmer down there grows somewhere between 24 and 36 plants on their farm. And they provide strictly to medical patients and did have an overage before 3460 was written. The reality is most of them either donated it to other patients at no cost or pushed it to the black market. I saw a lot of that when I ran Southern Oregon Normal. Therefore, we tried to help them to funnel that into a legal market by helping to create 3460. Now you have to purchase a special license through OLCC. And those small farmers can't afford that. They still give their medicine away for free or at a very low reimbursement rate.
Now, are these going to be licensed OLCC growers now?
Some are. Some have chosen to give away their patients and only grow for themselves. A lot of patients in the whole state have lost their growers. You all have talked about that in these meetings as I've sat here over the last year or so. I was one of the first 500 card holders in this state 17 years ago, almost 18 years ago. I've seen a lot of changes. been in lots of meetings, lobbied with Anthony, lobbied with a lot of us. Right now in Jackson County, people are being cited in the city of Medford for growing 10 plants. One card is a patient card with 6 plants and 4 rec plants. The patient lives in Klamath Falls, the grower is in the city of Medford, and they are now being told they have to cut down the patient's plants. Well, the patient went to an exorbitant amount of money to be legal, be compliant, and they have 3 days left, and they have to cut down their plants. How fair is that for that patient that spent all that money to be compliant with our state law? The patient is dying, she has AIDS. They can't do anything for her but cut down the plants and give them immature plants. Is that okay? Is that okay that Jackson County is the crown of the Emerald Triangle, growing the most luscious medicine? Where is the state of Oregon and the medical marijuana program now to protect that patient that's going to die because she has AIDS? And her grower has lived on that same piece and grown for her for 7 years. What are we going to do to help them? Her, the children. Do you know how many children are grown for in Southern Oregon that have autism, that have seizures? Their growers are still growing for them against the ban because we have a passion for those patients. We have a passion. We had a passion when we ran our facilities and were raided. We had a passion when we sat in jail and worried about the police confiscating our growers' addresses. We had a passion when we went back to Salem and continued to lobby while we were felons. But now to hear that my patient who has AIDS has to lose her medicine just a few months before we can harvest it, after she spent all that money to be legal, that's what creates the black market. So I ask you, what are we going to do? What are we going to do for her, Andre?
I think, is that a rhetorical question?
What is OMMP going to do for the patients that have been at the same grow site for 7 years? And now places like Medford and Jackson County are getting these bans in place.
You know, I think there's an interesting and realistic play between local governments being able to regulate marijuana and conformance with state law. And I think localities are having a real problem with regulating it appropriately. They do have, and I've been in contact with Jackson and Josephine counties, and I'm actually traveling down there this month in September to talk to local planning commissions. We're limited on how much information, we can't provide any information to localities on grow sites. It's confidential. Now, if law enforcement calls us, we can give them yes or no and the plant limits, and that's about it. So, you know, OHA is just, we need to know where local bans are. We want them to give us that information. We evaluate it, and then, you know, if we see something is illegal, we say, hey, your ban or your prohibition might be counter to state law here. Go talk to your lawyer. But that's kind of the extent of the advice. We can't really give them any legal advice. They're not our lawyers' clients. So I recognize that there is a huge issue with the localities being able to differentiate what are legitimate grow sites versus those that are not legitimate. And I feel that OHA's hands are tied based on the information that we can provide those localities that would help them make that differentiation. I wish I could say more, and maybe I can in a private setting, but I won't in this public setting. But we're aware that there's a problem with communication between the state agencies, not just OHA, but OLCC and ODA, and localities and the way that they manage and regulate, whether it's medical marijuana or recreational. So we're aware there's an issue. We want to be helpful to localities, and we want those localities basically, because that's the bottom, you know, that's where democracy starts. That's direct democracy with local government involvement with their citizens there. We think that there needs to be better communication with localities and OHA.
Today in Medford, they're having a city meeting, and they are going to be addressing this.
And there's simply a lot of land use planning and zoning issues that OHA just doesn't touch and we stay out of. And that's going to be up to localities to determine how they want to deal with those zoning issues. As long as they're within statutory framework that the legislature's allowed them to regulate. So time, manner, place restrictions.
So I hope that I've presented to you what creates a black market through really no other choice for the patient.
Thanks, Beth. Doug Bach?
Hi, I didn't really come to speak, but I did sign up. So first, I'd just like to thank all of you for your earnest efforts on behalf of patients and people that are trying to help them out there. A question that came up at lunch as I was talking with where I have my card down south, and submitted to have a medical grow on this property well over a month, 6 weeks plus ago, and now trying to pay that $200, but they're not, it hasn't gone through evidently. And so they're being denied the opportunity to pay and become compliant in time for September, because evidently I guess it's just a backup, and so the authorization of the grow site has not hit the other end of it to where they're collecting the money for the multiple cards. Any suggestions, or should it be a concern?
I can get more details from you after the meeting and to deal specifically with your case, and then I'll try to get some more information for you.
Sounds good.
Okay.
Thanks, Doug.
Related to that, plant count limits, when we say plant count limits, we're dealing with mature plants, flowering plants, correct? Just for definitional purposes. Okay.
Lloyd Morley? Eva? Lauren Terry?
I didn't know protocol. I apologize for interrupting earlier. I was positive.
That's okay.
One
No,
way
it's
or else
okay.
and ask questions.
We were soliciting your information too, it's okay.
My name is Lauren Terry. I wrote for the Willamette Week for their weed column. I was their first patient columnist back in 2013, and since then I was the first one to write about 1531, and then I started working for a few dispensaries, helped open one, watched it explode, and now I work for a grower in Southern Oregon. Just as a little background, and I really appreciate your diplomatic and pragmatic explanation earlier, because we know that we messed up the Second Amendment a long time ago, and like you said, we voted for 91, and we're going to do the best we can with it, but I also understand that there's only so much that can be done after the entire state voted to pass something that explicitly gave the OLCC the power. That being said, I just want to make the point that it's not just that making the transition from medical to recreational is not, it's not just a challenge literally, but it's leaving something that you can feel very good about. It's a very rewarding program, the medical marijuana, just because Oregon's has been such a standout. Our program, even though it took a lot of time to get straightened up, shoot, look at California. I mean, we are so far ahead of any other medical program in the world. And then to have to, in order to continue doing what we do, to have to not only sign up with a very different program, but to associate with liquor is what really feels so freaking wrong. And like I said, I know we voted for it, and it is what it is, but that's another element. It's not just that I would rather be legal, it's that, boy, I feel like I'm doing the wrong thing right now, period. But more on that transition, literally, for people that are in counties, like we're talking about counties that are opting out, or for example, Douglas County needs to vote still. Those people haven't been able to put their recreational application in yet because they don't know yet. They can't get a city license because the city's going to decide. Let's say they've got 50 pounds harvested this October, and they get a recreational license mid-year next year. If I've got 30 pounds that I grew medical, and I've got my rec license, if it was properly packaged and labeled, would that medical stored, ready to sell stuff be able to go to a rec shop?
What I understand,
Yeah, go
I
ahead.
just did the transition for a medical farm, and if you had existing plants used for marijuana, there's a tracking system in a specific way that you write it out in the CTS. So yes, you can transfer over.
It transitions in.
So the best way would be to do things recreationally while you're still medical, if you anticipate that you're gonna have to do that, because aren't they two different tracking
No, you
systems?
stay medical and then you've applied and you ask for a transition date after your harvest.
I see, okay, there's a process, awesome.
Well, we're all struggling with this process.
There's a one-time.
It's a one-time, transfer exemption.
Okay, that makes sense, that makes sense.
And your patient has to authorize that.
And then in regards to medical laws as they are right now, I mentioned that my farm was vandalized earlier this year, but we experienced full-on arson. It was very frightening. A full trim shed that used to have people living in it for months at a time. We all happened to be gone this spring because we weren't working on the farm, and it came back burnt to the ground. Some kids came down, we caught them with cameras, but it was extremely frightening. And I wanted to make the point that the way the laws are right now, there is no place to legally put your product other than your farm or a licensed dispensary. Which, if you don't have a dispensary associated with your farm that is vertically integrated, it's the most dangerous requirement to force upon people to make us continue keeping our stuff at a place that is a target for thieves. And as you know, with the security requirements, people do what they can, but if you're more remote and you don't have to have all those security requirements, people aren't gonna pay for a lot of that because it'll just be expensive. So I just wanna make the point that I think we need to make some sort of way for, if I wanted to keep it at one of my properties, I think I should be allowed to do so. If I am a licensed grower, I have licensed product that is stored and aptly labeled and covered and not just childproof, can't be seen, can't be smelled. I should be able to put that on a private property that I own that is not exactly where it's being grown, where I have obvious greenhouses, and just because, unfortunately, regardless of advocacy, legal costs, people steal. Southern Oregon is a dying economy with timber towns. Kids don't have stuff to do. Look at the meth arrests. It's trouble. It's unfortunately thieves. I'm born and raised in Roseburg, and my dad was a defense attorney throughout the southern counties, and I think he took a big hit when he stopped representing thieves, I'll say that. So just something as far as storage specifications, I think those would be huge for long term, whatever happens with medical growers. But thanks very much for all your work.
Thanks, thank you. Sunny?
Hello.
Oh.
Come on up.
All
You
right.
won't be able to, Tristan and Todd won't hear you otherwise.
Hi Todd, how are you? Hi Tristan. Oh my God, I had it up right
Hi.
here. Let me grab this, turn this back on here. I don't know what happened to it, but I had it all ready to go, and then I stood up and it just disappeared on me, so anyways. So I was told that I can take this opportunity to say anything, pretty much. It is cannabis related, and basically it goes down to the fact that as a cannabis community in Oregon, we need an association for industry that is run by vote and not by ego trips. I'm an independent party who desires an opportunity to be of service by helping structure and maintain a coordinated, sustainable, and responsible cannabis association that fairly represents legitimate, responsible business owners and patients from all facets of the Oregon cannabis industry. The association, this is just a breakdown of what will happen as part of the structure. The association will be run by votes for all positions held, not self-appointed positions that never change. Initial positions will be temporarily given to qualified parties to be held until first election. All interested parties, please submit resume and relevant information which makes you qualified for the temporary assignment to this position. I believe that as a true entire industry representing association, we will have a director of each section of the industry so that we ensure we are representing the industry as a whole. If you see an area of industry not specifically addressed, you feel it is important, please let us know. We can discuss adding it or modifying. Right now, these are the proposed board member positions, are 5 to 9 positions. And I'm just going to briefly run down the list of what's been proposed. First, you have the one director of the association, director of patient policies, director of indoor grow processes, director of outdoor processes, director of edibles, completely different, director of topicals, director of concentrates, director of laboratories, director of minority affairs. Not only this association's focus will be on educating its members and empowering its members, but this association will serve as an invaluable liaison to the OHA, the OLCC, DOJ, legislature for policy because of its fair and well-planned centralized democratic structure, truly representative of the overall Oregon cannabis community. So, in closing, we welcome you to apply for a position as soon as possible, as we already have received a few applications of interested parties and want as many as possible to choose from. All parties not chosen for director will be a part of the original committees for that area of industry that will form all our policy for the upcoming legislative session. I strongly believe that we need a real industry voice, and yes, that means recreational and medical together, and not just the voice of one region, one person, or one law firm. All are welcome, and thank you.
Thanks. PK?
Okay. Pete Kramer from Mercy. Thanks for Dr. Phil Lebec. If you remember him from the beginning, he was a great fighter for the medical cause. I'm here with my concerns with the medical people. A lot of the patients have lost their growers because the growers went to, hey, I'll just grow for myself. You're asking too many questions on this plant. And the prices, no. How can a person that's on Social Security or on WICs or this, how can you come up with $200 just for this little piece of paper to protect you from Guido from beating you up? Now you want to have another $200 to have a grow site. The patient can't even get out of her wheelchair. That's what OMMP was formed for, to help the patient, to have a grower for the patient. When they passed OMMP back in 98, they went over Section 20 of our state constitution, where they were going, where everybody's equal. No, some people pay that much. Some people pay this exorbitant amount. It's all for the same thing. Section 20 says there was no law that should be passed that way. And look, for the last 15, 20 years, people are paying outrageous prices for the protection for their medicine. Does your mother or father pay protection to go down to the pharmacy to get their pharmaceutical drugs? Thank you. You've been all doing an excellent job. We can do better. I hope I can help out. Hey, I'm all dressed up. Let's go fly a kite.
Okay, do we need to schedule our next meeting? So what we're going to do now?
I mean, we can discuss that over email, what
Okay.
the best dates would be.
Hey, please get in touch with me. I didn't find out until a couple days ago about this
Okay,
meeting.
before I leave today, I'll get your email address.
And we'll put it on the website. All dates and meeting locations are on our website, on the OMMP website. I guess if you guys have dates that are off limits, send them to Shirley, just saying, hey, I'm on vacation these dates, just so we know what dates not to schedule something.
I have a quick question regarding I guess what it's called, report that you're having, if you want us to do. I would like to get something by email from you, kind of on the details of that again.
Okay.
Would be really nice. And then also, I agree with Ben on maybe scheduling a special meeting so that we can discuss this, even if it is by phone or if
Yeah,
someone
I think
can
we
be
can do
present.
certainly by phone.
I mean, I'll drive, it doesn't have to necessarily be Portland, I'm willing to travel to.
Yeah.
We can do a conference call specifically with dealing with the report.
Yeah.
And if we feel like we need to get together and
Then we
subgroup,
can.
then we can.
But I think it'd be nice if we all kind of did our own and then come together again, because this really helps me being on the judge. You know, what my thoughts are sometimes.
Okay.
Because I know sometimes I can get a little.
So what I'll do is, in the next couple weeks, I'll set up a conference call to discuss that report.
Yeah.
I guess in conclusion, we keep hearing concerns about some of the fees, Andre. What's the purview of this committee in regard to making recommendations about fees?
We talk about it
Every meeting,
You can make the recommendations every meeting.
every meeting.
And what happens?
Every meeting we talk about it. Sorry.
Do they go up?
No.
Do they?
I mean, no, people are aware of the financial constraints placed on this program and the obligations placed on this program. Legislature's gonna have an interesting session.
Okay, fair enough.
Say something.
Well, the problem is, ladies and gentlemen, this goes in the general fund, and they've got to find money from somewhere else if they don't use this money. So it may not be politically palatable to take money if we have an overage of cards, but we're having a big change now. So this year is going to be really much a transition year.
A huge one.
Anything else? Okay, meeting's adjourned.
Thank you.